Good morning. My name is Ian Patterson, and on behalf of my co-chair, Dr. David Burney, we're very pleased to welcome you to the first ever Rare Cardiac Conditions Conference. To help us launch today's inaugural conference, Dr. Thierry Massana has kindly offered to give a welcome address. Dr. Massana is the President and Chief Executive Officer of the University of Ottawa Heart Institute since 2014, and he's also the past Chief of Cardiac Surgery at the Institute. He has published over 300 scientific publications and has been invited to lecture at many national and international symposia. Thank you, Dr. Massana.
Well, thank you very much, Jan, and good morning, everybody. I really thank everyone to join this very important meeting. I have to say, as the CEO of the Heart Institute since almost 10 years now, I'm extremely proud of this initiative. I really want to congratulate you, Jan, of course, and David Burney, and big thanks to Bonnie Chan, who organized this wonderful initiative. Well, I don't need to emphasize how important as the rare cardiac conditions, but actually the meetings are rare as well. So this is a good start for this important thing. I think we focus a lot on the main disease, what I call the big four, like coronary artery disease and valvular disease or heart failure or arrhythmia. But I think the rare disease are very important because there is definitely a better need for education, training, understanding of these diseases, and to actually also join efforts and share experiences, because as by definition they are rare, so very few centers, beside maybe a few centers, have a large experience of these diseases. So we may need these meetings frequently to share experiences and to progress in the treatment of these very devastating diseases at time. So I think all of this started with I think conversations we had with Dr. David Burney, and then further with Jan, when I remember I asked David, so David, what we should be doing better at the Heart Institute was a couple of years ago. We always want to be better and say, Thierry, we should really have a heart team for rare cardiac diseases. And I think we expanded the heart team concept that we have significantly promoted at the Institute across all activities to the rare conditions, cardiac conditions. So now we have a rare cardiac disease team. So I'll stop there. I think you guys are eager to learn more, and you're not going to learn more a lot from me because I'm not a specialist in rare diseases, although I have operated a lot of rheumatic valve disease in the past, where I was before Canada was not rare, but here it's rare. So this is also something I want to point out, that some rare disease we see here are not so rare in other parts of the world. So I think these meetings have a lot of potential, in my opinion, to become international. So I stop there. I want to thank you all for being present. I'm very impressed by the attendance. I think it's around 300. This is a huge success. So thank you very much, Jan. Thank you, David. And have a great day, guys. And thank you for joining the Heart Institute meeting on rare cardiac conditions. Thank you, guys.
Thank you very much, Dr. Massana. Okay, here are my disclosures. So before we get into the meeting, I thought it would be good to have just a little bit of context on what are rare diseases and sort of briefly have an overview of our agenda for today. Most countries have defined a rare disease as a condition that affects less than 1 in 2,000 of the population. And in the US, they actually came up with a definition back in 1983, the Orphan Drug Act, established a rare disease as a condition that affects less than 200,000 people in their country, which would translate in today's numbers to about 1 in 1650. The EU has a definition of a prevalence of less than 1 in 2,000. Interestingly, to the best of my knowledge, Canada does not have a clear definition on rare disease, although, like I said, most countries are using 1 in 2,000 or less. Some other quick facts about rare diseases. There's about 7,000 that have been identified in the world, and about 80% have a genetic basis to them. And because there are so many rare diseases, it affects about 1 in 12 people. So in Canada, that translates to 3 million people having a rare disease, a rare condition. And worldwide, that number would be 500 million people. Unfortunately, there are no FDA-approved treatments for 95% of these diseases. What I recently learned was the Ontario government in 2017, the Ministry of Health convened a rare diseases working group, and they wanted some advice on a strategic plan on how to approach rare diseases. And so this working group came up with 3 main recommendations, which I think helps provide a framework for our meeting today. So the first recommendation was they thought we should try to improve access and care to this marginalized group of patients. And one of the things they suggested that we do is develop a comprehensive network across Canada, but even worldwide, of healthcare organizations and providers and researchers who are able to help grow knowledge and provide care for these patients. And then the second advice they gave, a recommendation, was to support equity in service provision. So they felt that patients with rare diseases should have the same access to care and the same access to experts as any other patient would have. And then the third recommendation was to foster innovation in disease discovery, management, and treatment. And really much of this morning's plenary is dedicated to this third recommendation. And to be honest, I'm not really sure how the Ministry of Health in Ontario is following through with these recommendations. But I think what you'll hear today is that many of us in the community are taking these recommendations, whether we knew them or not, and trying to deliver on a lot of these recommendations. So with this in mind, we came up with an exciting agenda for you today. And the meeting is largely divided into 2 parts. There's a big plenary session this morning where we have one group of speakers in the earlier hours and then another group sort of later morning. We have a break between those 2 sessions. And we'll hear about rare diseases from leaders in nationally and internationally. And then this afternoon, many of you will be breaking out to sub-meetings, specific specialty-driven meetings, and that will also be very invigorating with a lot of interaction with the group. And then we'd ask you to come back, if possible, just to this platform at the end, just for some closing remarks. And we have a couple of questions we wanted to ask you at the end. And now just briefly, a few housekeeping items before we start with our first speaker. This conference just recently was approved for CPD credits, up to 6.5 hours of Group 1 credits. So we will be sending you an evaluation form to complete at the end of the conference, and then we will be emailing you your attendance certificate. So be on the lookout for that. This conference will be recorded and will be available for viewing afterwards, and we'll provide you all with a link to that as well. And then the question and answer period at the end of the plenary sessions, we have, so there'll be 3 speakers this morning, and then at the end of the 3 speakers, there'll be time for questions. So we'd ask you to please wait until that time. You can put questions in the chat in the meanwhile, but in terms of speaking and raising your hand, we'd ask you to wait until the panel discussion, which is at the end of the hour and a half. Okay, and then finally, we're ready to start. So it gives me great pleasure to introduce my co-chair, Dr. David Burney. He'll be actually moderating and speaking during our first plenary session today. Dr. Burney is the head of the Division of Cardiology since 2022, and he's a staff electrophysiologist at the Heart Institute since 2002. And relevant to today's meeting, Dr. Burney leads the cardiac sarcoidosis program at the Heart Institute. He leads a national registry on cardiac sarcoidosis, and he's chaired international guidelines on the diagnosis and management of this rare condition. He's been involved with several 500 peer-reviewed publications and presentations, and he's leading several peer-reviewed funded trials, including one CIHR-funded RCT on the management of cardiac sarcoidosis. So with that, I hand over to David.
Yeah, thank you, Ian, for that introduction. Just before I introduced our first speaker, just two additional notes on the conference. The first is to highlight the lovely emblem in the top right-hand corner of the slides, which is actually Ian found, and basically the emblem of all rare cardiac diseases in the world. The second thing to point out is that we've, as part of our initiative here in the Heart Institute, we've developed a rare cardiac disease fellowship program. This is a 1 to 2 year mixed clinical and research fellowship. Fellows can come and they can choose actually the makeup of their program. They can rotate through multiple diseases. They can major in one disease and minor in other diseases, but that's now open for applications. So now I'll introduce Andrew Cran. Andrew Cran is a long-time colleague of mine in the arrhythmia world. He's grown to be a tremendous friend. He's someone who's mentored me in my career, for which I'm very grateful. He's a very busy person. He's currently the chair of and chief of cardiology in Vancouver, current president of the Heart Rhythm Society, immediate past president of the Canadian Cardiovascular Society, extremely productive clinical researcher, and somebody that I always learn something from. So over to you, Andrew.
Well, thank you very much, David. I trust everyone can hear me. Just loading my first slides here. So can you see the slides now? Oh, please, someone say yes.
No, I have to say no.
Have to say no. Okay. Well, we had a trial run of this. I've got share turned on. I'm open to advice.
We'll ask. I do like your shirt, though, Andrew. It's very sharp.
Thank you very much. Is that any better?
Yeah.
Okay. Very good. Well, I'm going to start with a pun and say this is a rare opportunity to present at a rare disease meeting from another continent. So thank you to the co-chairs and organizers for asking me to speak and being willing to do this as one of the early speakers, in part because of the time of day here. And what I wanted to do today really is tell you the story in a way. It's a bit of a career story. It's a bit of a journey in terms of how we've come to a point now where I think we've been effective at assembling a community of people who do a broad range of things around studying rare diseases, and then some of the lessons that are learned from that, and hopefully leave sufficient time so there'll be lots of time for exchange later, which I think is most important. So I have nothing to disclose. So let's start with one of the inception moments. So I was a fellow literally 29 years ago and was sent down to supervise the treadmill test on a 10-year-old boy whose grandmother had died 3 months postpartum giving birth to his mother. And this 8 and 10-year-old boy, whose first name, I remember their names, remember their faces even, I remember those two boys. And I asked my boss, why am I being sent down to supervise a treadmill on these two kids? And the answer is, well, they have long QT. And I said, what am I looking for? And he said, arrhythmia. And in heart rhythm specialist speak, that's a little sort of joke. And what I realized is that because their mother had actually had an exercise-related cardiac arrest, we were doing treadmill tests to sort of stir up trouble. It's very much the theme of EP. But in fact, had no idea what to look for, what to measure, whether it was good or bad, what I was looking for. And I realized nobody knew the answer to that. And so I knew a little bit about long QT at the time, but not very much. So I went to read up about it, and I realized there was a huge vacuum in our understanding of this condition. This was long before there was genetic testing, although not that long before. And so I then took two steps. The first step in that journey was to say, well, how many patients do we have here? This was in London, Ontario. How many patients do we have of this condition? And the answer at the time was, with some hard work, was probably about 12 or 14. So in a relatively big practice, that's not very many. So I think that qualifies for today's talk as being a rare condition. Although interestingly, it took about 15 years later, we learned that the prevalence was probably about 1 in 2,200 or 1 in 2,000. So it's on the cusp of that EU definition. And so I then realized that if I wanted to understand this, then I needed to increase the scope of this to understand what the natural history was, what the diagnostic and therapeutic issues were, and so on. And so I did what most people did in that situation, is I reached out to people that I knew. And so a co-worker from Ottawa Heart, who is a dear friend, is Martin Green. And I reached out to Martin Green and to Jeff Healy and to Chris Simpson and said, could 4 Ontario centers join their experience in this kind of rare disease to in fact have something of a database or registry to understand it better. So that was one inception. That was the sort of beginnings of this idea of studying rare conditions requires scope and scale. And to do that, you need to reach out and create partnerships with other organizations. So here's the next one that was a few years later. And so this was a young woman. Her name was Angela. And she had a cardiac arrest around a swimming pool. And it wasn't quite clear exactly whether she was in the pool, she wasn't diving in, she was there with her 2 lovely daughters. And when she came in, there was something very interesting about this. So the first thing was that her cardiac tests were for the most part normal, not completely, but fairly normal. She had no personal or family history of any medical illness whatsoever. And I was trying to figure out why she had her cardiac arrest. And we did a treadmill test because swimming, couldn't do a swim test with an EKG. So the treadmill was the next best thing. And she had a few skip beats or PVCs, but certainly nothing diagnostic. And then I had a fellow who was interested in some of the basic science behind channels and so on. And he said, why don't we give some adrenaline? And, fellows will do that. They'll sort of propose unconventional things, either because they don't know better or because they are adventuresome. And we gave her adrenaline, and she lit up the monitor. She had complex ventricular activity, did not have another cardiac arrest, but if you like, showed her hand that she had a genetic condition that predisposes to cardiac arrest. And then she went on over time, actually, interestingly, to develop more clear evidence of the genetic condition, and ultimately ended up actually having a cardiac transplantation. And it was a long journey to understand the basis of this, but it really triggered my interest in the whole idea of explaining cardiac arrest and sudden death. And that then led to the question, well, something like this was even less common, truly unexplained cardiac arrest. What we should do then is take our network of 4 places that by then had heart and stroke funding and expand it to 8. And so I now stand by you here 29 years later saying that 4 became 8, became 11, became 13, became 16, became 18, and it's now 24. 24 sites across the country with escalating scope. And I'll tell the journey of the creation of what we now call the Hearts in Rhythm Organization, or HERO. And a little background to that. So that, as is often the case, specific incidents really trigger the progression of stories. So what really started was this idea of unexplained cardiac arrest and trying to study that in scale around 2004. So about 10 years later, we received grant funding to take this going forward. And that unexplained cardiac arrest, the acronym for that is CASPR. That was a very successful venture that also helped to expand the network, with the goal that we would get into the business of formally studying the individual most common inherited cardiac conditions that lead to sudden death. And so this is a bit of the grant support that came about. So this is heart and stroke, and then CIHR, which is the state of it now. And then the individual conditions that we added are ARVC and long QT. And as I'll show you a bit later, we have recently changed the scope of this somewhat and have also added Brugada and CPVT as other disease-specific registries within the overarching program that's been developed. So the next big story, I think, in this situation has to do with what happened around, probably realistically, about 2015. One day I sort of woke up and I realized that bringing together physician researchers, and at the time we had about 12, if I remember right, maybe 14, bringing together physician researchers to try to answer these questions was not good enough. And one of the reasons it wasn't good enough is when I asked myself, why was I doing this? What was the sort of inception idea around this large-scale Canada-wide registry or database approach to things? The answer was I wanted Canadians to have access to experts. And so two things. One is having sites was not the same as having multidisciplinary clinics that involved the breadth of expertise necessary to deliver expert care. And that involves pediatric and adult cardiologists, geneticists, imaging, pathology, a range of different people assembled in a team, and then with it, researchers and learners. And so in that moment, I had this notion that what was previously what we called the Genetic Heart Rhythm Research Network should become the Hearts and Rhythm Organization, because it should involve care providers. So this is genetic counselors, nurses, technologists, physicians, and it should also involve patients and families. So we quite intentionally actually put that mesh together, if you like, because these are people who are used to living in their lane, put that group of people together, and I'll show you where that's come, because it's been quite rewarding, and I think it's part of the reason why CHR saw merits in the idea of integrating discovery with utility with application and knowledge translation. So that's kind of what's behind the hero story in my mind, and there's been some rewarding things lately. So here's that graphic version of that same story to say that, typically we think of these things as research questions, but in fact, much of the discovery that happens in research is not terribly useful if it doesn't actually get to the point of the healthcare professionals that apply it. But really, in the end, we're trying to change the outcome for patients. But this is the historical model of these sort of spheres of activity, if you like. And in fact, this is what we gave birth to, was this idea that we have a breadth of people that are all in the same tent, trying to learn each other's language, trying to communicate and discuss things and so on. And so, for example, right now we have the organization has what's functionally a CFO on our executive, and he is a parent of a young man who has one of these inherited conditions. And the chair of our executive is a genetic counselor. So this is not intended to be a physician researcher driven thing. It's intended to be an organization whose goal is to save lives and identify, discover, and apply the mechanisms by which to do so. So I now, many years later, you see the stars here, which are the sites within the Hearts and Rhythm Organization, or HERO, where we were trying to dot the landscape with sites that are now multidisciplinary clinics that do this for patients and families. There are a couple minor gaps, but you might notice this basically tracks the population. And the places where there are gaps or where there's opportunities, if you like, they're narrowing, and they've also been offered and haven't yet seen the merits in joining, but we continue to chip away at trying to expand that so that this really is as national as it can be. There we go. And this is just an example of all the institutions that are involved across the country. So this really is a very pan-Canadian initiative, trying to study these rare inherited cardiac conditions together. And this gives you an idea of the scope of what we're working on. And so now, after all this time, we have almost 6,000 patients in the registry, and they are patients and family members, including unaffected family members with these different genetic conditions. Some things like Brugada and CPVT are relatively new in terms of fully reimbursed data sets that we're collecting on patients. And with this in gray, what you see are the biobank samples, because we obtain a biologic sample on roughly about half of patients, even though an opportunity to donate a sample is given to all patients. And we've also embarked on, and within that ARVC envelope is other forms of cardiomyopathies that predispose to sudden death. So that's another mechanism. So the question is, what is HERO? And I think I've initiated or I told you about much of this. This is a holistic approach to research. And holistic in the sense that it's inclusive, it's national, but it also involves the care providers as well as patients and their families. And again, the goal is to standardize and improve care. And I'll show you a bit of how we're doing that. So some of you will know me from some of my leadership and administrative roles, and so can't help myself, but if you like, help to create an organization. And the organization has some of the things that many, particularly the member organizations I've been involved with, include, and that's things like a vision and a mission that you see here, you've likely read ahead, as well as goals. And I think for today, you highlighted one key thing, which is to facilitate collaborative research and engage the patients and families in the process. So we get genuine guidance on what's important, what are the more pressing issues, how things can be applied. And the nice thing is that we also work with our agencies such as the SADS Foundation so that we have a knowledge translation and dissemination process that then leads to identification of more patients and families, more prevention opportunities, and more enrollment. So it helps to identify those patients within that rare disease network kind of context. Our governance structure, as I said, involves an executive governance committee and 5 committees. One of those is a dedicated research committee. And what's most inspiring to me as an old fart is that there's actually six individual researchers in the first 7 years of their career who are really inspiring, take it up a notch kind of people. They're dotted across the country. And they have interests that are well beyond my original vision of how this would work, and that's what's so great about it, is they're taking it up to a next level or working in expanding directions. And so I'm quite optimistic that I can get run over by a bus, and this will carry on. There'll be a short period of mourning, and then some of those superb people that are within the organization will take over and manage it very ably, although I certainly have no plans to be run over by a bus. One of the points that I try to make along the way that I believe is something to think about is if you apply this in the area of rare diseases, but I think it's true for all of clinical academic medicine, is that providing excellence in care with a curious team that's trying to ask questions of why they can't do a better job or answer the questions or have better outcomes. Embedding research within the clinical provision of care, particularly around rare diseases where expertise is so needed for something that's uncommon and most providers are not experts at, I think is a fundamental principle to think about. And so we're fortunate in that the focus has been clinical, and in that way, the idea of coalescing experts in multidisciplinary clinics and then embedding research within those processes has then allowed that to really hum from the standpoint of, for example, the majority of patients that are seen in any kind of clinic encounter are enrolled in research in one or more fashion. And when you start to do that, then you gain some economies of scale, some efficiency, staffing clinics and enrollments, and biobanking and so on becomes a much more financially effective model for conducting research. And then, of course, the success of rare disease study is by scale as well as by asking and answering the right questions. So I just want to show a couple things here in the tail end of the presentation, just to give you an idea of some of the things that we're working on. So some rewarding things are, we have content and publications in good and outstanding journals that include gene discovery, utility of genetic testing, optimal phenotype management, care processes, quality of life, diagnostic algorithms. We've been part of defining how to diagnose long QT and approach the diagnosis of cardiac arrest and so on. But part of this in our website, for example, is a toolkit. So a very rewarding thing is we've had several clinics where we've basically mentored the formation of a clinic. And if I look back at how many multidisciplinary clinics there are in Canada, every 5 years, the number almost doubles. And that's because, in part because we're trying to provide an opportunity to fast track those clinics into an administrative logistic care path kind of system and provide them with a toolkit for things like patient information, patient correspondence, communication, how you reach out and connect with families and so on. And then with that, it's coupled to two things recently. One is we have case rounds nationally, and each of these initiatives is run by different people within the network. So this is definitely not about my leadership so much as trying to enable, especially the younger generation. It's led sometimes by patients, family members, providers, as well as research-focused individuals. And these are typically very well attended. Most recently, we launched knowledge translation rounds where we literally review our latest research to ensure that we fast track the discovery to application within Canada. We have active communities, and some of this has to do with the outreach of making sure what we know is applied. And so things like AEDs in schools, syncope awareness, partnership with SADS Foundation, and so on. These are key partnerships. So the good news with all of this is this vision of integrating patients, families, and care providers into enterprising research resonated with CIHR, and we were provided with a foundation grant. It's very nice to have long-term stable funding, and this is obviously something that is not easy to come by. And that's one of the big challenges in this situation, is to do this, even though the questions are often not that complicated. You still need funds, you need effort, and you need people. We have an annual meeting. It's now had 6 years. It's going to be in Ottawa on June 9th to 10th. So people who are interested, please feel free to join us. Simon Handsome is the lead, along with Dr. Green and their team. And typical attendance is 80 to 100 individuals. And again, that includes patients and family members. So it's an interesting mix of people, and it's not like most meetings, that's for sure. We collaborate with about 6 different groups globally in terms of people who are looking for larger scale collections of either biobank samples or data sets to try to enhance discovery. And again, I've talked a bit about the knowledge translation platform, and I think I have a nice slide created by Brianna actually that illustrates this not only through our website and its content, but also through social media and a YouTube channel. So in the end, I wanted just to give a heads up about one thing that I think is the product of a long journey, at least for me, and that is my mentor at one point told me that I should just write down what I do, and that way it would be easier for other people to do it when you would come and see me in the clinic. And the end of this journey, practically 10 years later, is in fact what you see before you, which is something where we worked as a group to define the process of care for the 7 different kinds of conditions or ways in which patients and families come to our clinic. And that's illustrated in this summary figure that is going to be coming out in the Canadian Journal of the CJC Open. It's actually coming out right now. We're just literally in the proof phase, where we've tried to provide a process that's targeting the healthcare system, administrators, patients, families, and providers. It's not for experts, it's actually for non-experts to be able to see how care should happen. And in that way, try to set standards for how what Canadians can expect to be to identify and prevent sudden death and heart disease in these inherited rare conditions. So this kind of thing is very rewarding to me to be able to see that we have peer-reviewed content there that helps to define the excellence in care by systematically studying these rare diseases. So comments and questions, I would be very receptive to any kinds of questions that you have. I thought I had one more slide, but appears not. I had one about what have we learned. What I will say, what we've learned just on the slide that I made, but I can't see, is that a few things. One is it's a long game. So if you heard that story, even had I had all the resources and energy in the world, it could have been faster, but not a whole lot faster. It takes time to build those partnerships, the friendships, the funding, and the scale to identify the scope of cases when you're studying rare diseases. I think the second thing is there has to be a champion. I was that person, and part of that championing is not only convening and encouraging, but it's also getting funding. Those things are essential parts of things. I think the third thing is it's a team sport, a bit like the Google lesson. You will definitely not succeed if you try to do it all yourself. So the more you enable and engage and encourage other people, the better. And so one of the great things we have recently is this next generation that's really stepping up and racing ahead with their agenda, and also now breadth of new projects, but also funding and other things. So I'm very encouraged. There's somebody at my hotel door, so I'm going to have to go answer that. And I look forward to the discussion in the panel phase.
Thanks, Andrew. You better get the door. Just one anecdote. I was involved. Remarkable achievements there. One anecdote. I was involved for a few years with this, and we had a very funny discussion about what the right acronym should be, and one of the acronyms that was strongly favored at one point was CIGAR, which is very funny. Yeah,
CIGAR was the Canadian Genetic Heart Rhythm Network, but I think we are a little more progressive with HERO, and it resonates a little better with patients.
Yes. Okay, we'll talk to you soon. So next, actually, it's myself. That's so I will talk. So Ian's given me the following title to talk about: the challenge and importance of clinical trials for rare cardiac conditions. So these are my disclosures. A couple of advisory boards. The main disclosures is that all the cases I'm going to show are real patients, my patients, but the images in the cases have been changed for fun. The people in the images do not have sarcoidosis. So this is where it all started for me. This is Alicia from The Good Wife. She doesn't have sarcoidosis, but like most doctors, I watch lawyer shows and not doctor shows. So she came to me as a patient. I was on staff for 2 years at that time. She came to me with the following ECG. So she was only 57 and she already had second degree AV block. And as was the standard of care in those days, we put a pacemaker in her and we discharged her home. So she comes back 2 years later and she represents with feeling very short of breath. She's in the emergency room and they think she's had a pulmonary embolus. So they do a CT scan and they find that she's got pulmonary sarcoidosis, and they also find that she's got heart failure and an ejection fraction of 25%. So I investigate her and she gets this scan, which is our favorite scan in cardiac sarcoidosis research. It's a fancy PET scan. FDG is a radioisotope that's taken up and activated macrophages, so as a surrogate for inflammation. And she had a lot of abnormal FDG uptake in her heart and also elsewhere in her body. And she was eventually diagnosed with cardiac sarcoidosis. And she's a lawyer and she had lots and lots of questions for me. She said to me, you know, why do I have this disease? How should we treat it? What is my prognosis? And why did you not diagnose it 2 years ago? So I was very troubled by all of this. I went away and I read everything I possibly could in the literature about the disease. And I came back and I said to her, you know, I don't know why you've got the disease. I don't know how to treat it. Nobody does. Your prognosis is really bad, and I'm really sorry that I didn't diagnose it 2 years ago. So we made up, and she's still alive today and still my patient, and actually a patient advocate and a patient peer supporter as well. My second case was Steve. Steve was a bus driver. He was admitted with pneumonia and tachycardia. Now, he had a history of pulmonary sarcoid previously, so we were on to this disease by now. This was his ECG, which shows a typical atrial flutter. He got $1 million workup with an echo that was normal, a PET scan that was normal. If you contrast that with Alicia's PET scan, But he also went on to have a cardiac MRI. And if you look at the arrows, he had small patches of scar in his endocardium. And, you know, the question was how to manage these patients, and they really were the two ends of a spectrum of the disease. Alicia with this active clinically manifest disease, Steve with this inactive clinically silent disease. So, you know, I then made it one of my clear goals to find out more about this disease. And, you know, we now know a lot more than we did in 2004 and 2006. And I'm going to show you what we know. We know lots about the epidemiology. We know how to diagnose it. We know lots about the prognosis, but we don't know very much about how to treat it. And that's where the clinical trials are so important. So the epidemiology, we know that sarcoid is a multi-system disorder that involves the heart in about 5 to 30% of cases. We know that the Alicia form of the disease happens in about 5% of patients, and that the clinically silent Steve-like disease is about 15 to 30% of patients. And it seems that the clinically manifest patients are have a much more serious form of the disease. We also know a lot more about the epidemiology of cardiac sarcoidosis in the last 15 years. And one of the most important things we've found is that the severe form of the disease often initially presents to cardiology. They usually don't have a previous history of sarcoidosis in other organs. They usually present to cardiology, and the disease is usually clinically isolated to the heart. So these are three very important messages. And there's three specific populations that we found that sarcoidosis is actually quite common. First is idiopathic heart block in young patients. This is a small observational study we did here in Ottawa. We looked at consecutive patients presenting to our CCU with heart block and undiagnosed heart block with no reason for it in middle-aged adults. By that, we said less than 60 years old. And we found roughly a third of patients had undiagnosed cardiac sarcoidosis. So rare, but not so rare. We did a similar study, again, in the Heart Institute, a small observational registry study looking at patients presenting with idiopathic monomorphic VT. Most of these patients had coronary artery disease, but 14 of them had truly idiopathic VT, and we found that just over a quarter of them had undiagnosed cardiac sarcoidosis. Again, none of them had a previous history. And patients with severe heart failure, this is not from our center, but this was a nice study where they looked at the core samples when they put an LVAD in patients, and they looked at the histology that they got, and they found that 6 of these patients out of 177 had undiagnosed cardiac sarcoidosis. So we know a lot about the epidemiology. We know more and more about how to diagnose it. These are one set of international guidelines, and it's not really so hard to diagnose cardiac sarcoidosis. It's usually fairly clear from a combination of the clinical presentation, the other clinical features, advanced imaging, usually PET or MRI, and often a biopsy as well. And we now know lots about the prognosis. So you remember that I told Alicia that her prognosis was terrible. I wasn't quite so unsubtle as that. But we now know that the prognosis is much, much better. In 2006, when I talked to her, the best data available did indeed suggest a poor prognosis. But we're now seeing much more up-to-date studies coming out. And this is a study from the Finnish group showing that 10-year survival is over 90%. But the reason the survival has been transformed is because of research into rare cardiac conditions, and in particular, the early diagnosis of this condition, the liberal use of ICDs in appropriate patients, and the prompt treatment of the condition. So fourthly, we don't know very much about how to treat it, and that's where clinical trials are so important. So there's never been a clinical trial in cardiac sarcoidosis, but there are some systematic reviews. There's 3 of them, systematic reviews of current treatment. I'm just going to talk about the most recent one from our group. We basically initially started with over 3,000 citations in the literature, but there really was only 34 of sufficient quality to analyze in the systematic review. And the best data related to what happens when you treat heart block in cardiac sarcoidosis. So if you look at the bottom line here, the bottom line is the bottom line. If you, in the literature, there's 178 patients with cardiac sarcoidosis treated with steroids or other immunosuppressants, and about 42% of them, their AV block recovered. There's 21 patients in the literature that were untreated, and none of them recovered their AV conduction. These are the data on LV function in patients who were treated and untreated. This is studies looking at patients with initially normal LV function, and it seems that the summary of the data suggests that if you treat these patients with immunosuppression, you usually can preserve their LV function. In contrast, there are 13 patients reported in the literature that weren't treated with, and there was a substantial fall in ejection fraction in untreated patients. But again, the numbers are extremely small here to make too many hard and fast conclusions from. I'm going to flip to this one. This is the data on patients with initially severely abnormal LV functions. And as you can see here, most of the studies suggest that in these patients, it's too late for treatment with immunosuppression to make much of a difference to their ejection fractions. And most of these patients, their ejection fraction remains stable. There is one outlier study here. Now, the data on arrhythmia suppression is even more unclear. And in fact, there's a hint emerging from the literature that treating patients with immunosuppression in cardiac sarcoidosis may actually make arrhythmia worse or may have of no impact. This is just the data on PVCs. So the problem with the current body of data is summarized in this slide, and the bottom line really is just the quality of data is poor. Of the studies that got into our systematic review, only 2 of the 34 studies were deemed to be good in quality, and this is using a validated checklist for cohort studies. 29 studies were rated as fair and 3 were rated as poor. And the reason for that is most of them were retrospective, most of them are single center, none of them are randomized, and there was no blinded endpoint adjudication. So what we'd like to know about how to treat cardiac sarcoidosis is summarized in this slide. We don't know which patients to treat. Do we need to treat everybody? We don't treat all patients with pulmonary sarcoidosis. Some patients with pulmonary sarcoidosis, the disease self-resolves. We don't know which drug to use, first, second, or third line. We don't know how long to treat for. There's acute and chronic forms of extracardiac sarcoidosis, so presumably there's acute and chronic forms of cardiac sarcoidosis. And we also don't know how best to assess response to treatment, and we don't really fully understand what the goals of care are. And this is a very interesting editorial just published, why aren't we trying to cure sarcoidosis, the neglect of disease termination? So, the bottom line is to learn more about how to treat cardiac sarcoidosis, we need excellent RCTs. But there's many challenges to doing RCTs in rare cardiac conditions and rare diseases, full stop, and cardiac sarcoidosis qualifies by that definitions. And I've summarized the challenges that I thought were the key ones. It's never been done before. So what do you use for the primary endpoint if there's nothing to follow? The disease is rare. So again, what to use for the primary endpoint? and how to get enough patients and how to get funding. And these were the main challenges. So the good news is I wasn't the first kid on the block, and there was already lots of people thinking about this in lots of other disease states. I really enjoyed reading more and more about how people had already applied their minds to these issues, and these are just some of the papers that I got into as I read more and more about this. A lot of the literature relates actually to childhood cancer. Some of the childhood cancers are phenomenally rare, but they've already started to do clinical trials in these phenomenally rare diseases. So I read all of this. And then some of the key documents I read were this one. There's actually, I found there's a journal called the Journal of Rare Diseases. There's actually consortiums of clinicians who've applied their minds to this, and two position statements on the design of small population clinical trials. And the key points that I learned them, and the CHR grant reviewers were convinced by my points, are as follows. Number one, whenever feasible, the gold standard randomized clinical trial should be used. Number two, the primary endpoint is often inadequately quantified and validated, but the absence of good reference data strengthens the case for randomization. So quite the opposite in other clinical trials in common diseases, where you're taught to validate your endpoint and validate your endpoint. In rare diseases, it's the opposite. Number three, aim for simplicity of design. Number four, consider pragmatic compromises on significant levels, greater type 1 error, sample size, error margins, and other design elements. All of that's considered completely reasonable to do. Extrapolation should be used as necessary, including extending information and related conditions to reach conclusions for the target population. So I'm going to go through the design of our trial just shortly, and just highlight where we used all of these things to get our trial off the ground. So as we're talking about potential primary endpoints in rare diseases, you know, the challenges are they're rare. So we're never going to be able to do a trial with hard clinical endpoints unless the disease it has got a really poor, very, very poor prognosis. And as you can see from the registry data that we have, is that our disease is not got such a terrible prognosis anymore. You can use softer clinical endpoints, some sort of composite, but that's can be very challenging to do. And you know, George Wells has been teaching me about hierarchical primary endpoints, where different endpoints in your composite get different points and so on. And that was one thing that we certainly considered. You can use an imaging surrogate endpoint. You can use a biomarker surrogate endpoint. You can use a disease-specific quality of life as your primary endpoint. And we considered all of these as we were designing the trial. So how to get enough patients and how to get funding? Well, a little bit like Andrew, you know, we built this up in phases. I think about this in 4 phases. We initially published our own single center data, but at the same time, we started to build relationships and collaborations with other doctors across Canada with similar interests. In phase 2, we then took that network to a different level and got funding to become a formal network and start a formal registry of patients across Canada. We published a systematic review of treatment. We established and published clinical equipoise in the treatment. We then in phase 3 started a vanguard phase of the RCT using local funding, and this is very important to do, I think. And the important difference between a vanguard phase and a pilot phase is one key point. But the second key point is you have to show CIHR that you can actually recruit patients to your trial. So this is a very key phase. And then in phase 4, we applied for full funding, and this basically shows you where the timeline of how we did these stages, and we got full funding for the RCT in 2021. And this is the registry that we got. We don't have, I wish we had 5,000 patients like Andrew. We've got at the moment 564 patients in the registry. So this is the clinical trial and the methods paper. Our hypothesis is twofold. We hypothesized that using methotrexate and brief low-dose prednisone will have non-inferior efficacy to standard dose prednisone. Standard dose prednisone is the gold standard for treatment of cardiac sarcoidosis in the literature and in all countries and amongst all experts. Our second hypothesis was that methotrexate and brief low-dose prednisone will result in significantly better quality of life than standard dose prednisone. Now, these two hypotheses have been criticized by many people, but again, I come back to one of the key lessons about this is to keep your first clinical trial simple in design and concept. It's prospective, it's open label, randomized, but it's got a blinded endpoint analysis with one-to-one randomization. These are the inclusion criteria. We really wanted to focus on what was happening in clinical practice. So the patients who are being treated usually are the ones with the severe Alicia type of disease. So we included inclusion criteria to reflect that. And this is our randomization schedule again, kept it super simple because it's the first clinical trial, and it's just a 6-month randomization phase. Patients are randomized to prednisone in standard fashion against brief low-dose prednisone plus methotrexate. The primary endpoint, we debated this for hundreds of hours between, it eventually came down to a decision between an imaging surrogate biomarker or a quality of life as the primary endpoint, but eventually we decided to go with a primary endpoint of an imaging biomarker, which is basically a measure of left ventricular scar volume on a 6-month follow-up nuclear imaging study. Most of these patients have devices, so we couldn't use MRI in follow-up. So that's why we went with a nuclear imaging endpoint. And we use extrapolation to persuade the reviewers of CHR here, because this endpoint has been validated in other conditions as an endpoint, most specifically in coronary artery disease. So the reviewers were convinced by that extrapolation. And we have multiple secondary outcomes. You know, one of the key points from doing these type of trials in rare diseases is to get absolutely everything you possibly can out of the limited number of patients that you have. So we have plans for 20 other manuscripts from this paper, because for the first ever time in this rare disease, we're going to have clinical trial quality of data, meaning core lab read PET scans, core lab read MRIs, core lab biomarkers, etc. I won't go through all of these, but this just shows you how many of papers are going to come out of this trial. So the sample size, this is again reflects what we learned from all of my reading. We use really quite wide inferiority margins for the sample size calculation, and you're allowed to do that to keep the sample size down. So 97 patients per group doesn't seem like a lot, but it's still a lot when the disease is rare. And we got full funding. So it was off to a slow start because of COVID, but we're now up to 68 patients out of 192. We have centers all over the world. Cardiac sarcoidosis is very common in Japan, so we have a Japanese network of investigators. We've got some in the US, lots in Canada. We also have a network from the UK about to join us as well. I'll flip through these. So I'm very hopeful the first clinical trial will give us many answers to many of these questions, and we've already started the planning stage of the next clinical trial. Now that we have a clinical trial network, we all quite like each other. We like working with each other. We all, you know, I've tried to make it as clear as possible that the academic credit's going to be spread extremely widely. Anybody who wants to write a paper can have a paper. Anybody who anybody who recruits a single patient gets on the primary manuscript. So then the second trial is really going to focus on this question: what are the goals of care? Is the goal of care to suppress all inflammation on a PET scan? Is it to treat patients' symptoms? Is it to prevent progressive scarring? And there's really two schools of thought in the literature. So the next clinical trial is probably going to be randomizing patients to different treatment strategies or with different treatment goals, either therapy adjusted to control symptoms and prevent deterioration in ventricular function, or therapy adjusted to control symptoms, prevent deterioration in ventricular function, and to suppress all cardiac FDG uptake. So just a few conclusions that, cardiac sarcoidosis is a benign disease in many patients, but some patients with cardiac sarcoidosis can have a malignant course. In terms of treatment, we know a lot about treatment from registry studies and observational studies, but we still need to learn a lot more. And the next stage is to do high quality RCTs, and the first one is underway. Thanks finally to everybody in the Heart Institute, the cardiac sarcoidosis team, and also the wider team that's helping with the registry in the world and is helping with the clinical trial in the world. So I'm going to finish there. I'm not going to take questions at the moment, but going to pass the microphone and screen on to the next speaker. I'm going to stop sharing, and then I'm going to ask Jody Edwards to share screen next, and I'm going to introduce Jody Edwards, who's going to talk to us about why and how to perform population studies in rare cardiac conditions. Jody's one of the scientists at the Heart Institute, the Ottawa Heart Institute here. She's a friend and a colleague. She's the director of the Brain and Heart Nexus Research Program at the University of Ottawa Heart Institute. She's an associate professor in the School of Epidemiology and Public Health as well. She's also a director of the University of Ottawa Heart Institute Population Outcomes Research Unit, and is an ICES adjunct scientist as well, so does a lot of research with large databases. So I'm going to hand the podium over to Jody.
Thank you so much, David, for the introduction. Can you see my slides?
Yes, very nicely, yeah.
And hear me well? Great, okay. Well, thank you both to Ian and David for the invitation to speak today and for organizing this this nice event. It was very interesting to me to put this together. As David mentioned, I direct the Population Outcomes Unit, so do a lot of population-based studies and analyses, and it was very interesting for me to kind of apply sort of the context of population-based work to rare cardiac conditions, which I have less experience with, although I'm working a little bit with David and getting some exposure to it. But it was really interesting to look at some of the challenges that that are present and some of the ways that we can kind of innovate. Okay, so I have no disclosures or conflicts of interest to report. So Ian reviewed sort of the epidemiology of rare diseases and definitions at the beginning, and my definitions align with his. I use the US definition of any disease, disorder, illness, or condition that affects less than 200,000 people, which corresponds to a prevalence of about 1 in 1630. So there are between 5,000 and 7,000 known rare diseases in the world. And so, as indicated, on the individual level, it seems like it doesn't have as much of a burden, with only fewer than 1 in 2,000 affected. But when you really scale that to the population level, when you look at 30 million people in Europe living with a rare disease and 300 million worldwide, and affecting approximately 3.5 to 5.9% of the population during the course of their lives. So I think there's a real need and critical, interest in doing population-based analyses, because really these rare diseases do affect entire populations. As also mentioned, many of these diseases have quite a severe or very severe course. Most individuals face diagnostic delays. So on average, 9 years are required for a correct diagnosis. So I know David talked about a couple of years and his patient wasn't very happy, and many kind of face consistent delays and accessing care, which also increases the burden on this system, in terms of repeated testing and diagnostics. There's also, as mentioned, very few options in terms of therapeutically, and so only 5% of these diseases have approved therapeutic solutions. So this is another reason why population-based studies, are really needed to kind of map the epidemiology, the changing in trends of the diseases, and also patient characteristics. And I think this is hypothesis generating for some of the trials that David talked about in terms of, who might be what characteristics of patients have differential progress of disease, and who might be, response targets for these trials. And there was very recently in Canada in 2019 a rare disease survey, and it just was really impactful in terms of the impact both at the individual level on patients, but also for families and for caregivers, of these individuals. Most have had negative impact on their finances, on their work performance, a lot of missed work in for caregiving responsibilities, and almost 80% suffer from mental health issues that are related to the burden of having to care for someone with a rare disease. So I think that this, on the population level, translates to a very significant kind of societal and individual burden. So population studies, can really be informative in this. And there was a nice example in the literature that I found, which related to cardiac amyloidosis. So it in the past has been quite characterized with severe symptom kind of presentation and trajectory, and also associated with a very high 5-year mortality of 44 to 65%. And screening studies were starting to become, more available, and different diagnostics, and suggesting that actually the diagnosis of it was being overlooked, and there was a higher prevalence of occult CA than actually expected. But the population data on the temporal trends in epidemiology were quite sparse. So to respond to this kind of evidence gap, there was a Danish nationwide study that was population-based study that was conducted by Weston et al. And this is published just 2 years ago in 2021. In JAG. And what they showed, they used a Danish National Registry to kind of ascertain a cohort of anyone with amyloidosis from 1998 all the way to 2017. They identified just shy of 2,000 patients, and 619 met the criteria for CA. And they showed that there was, in fact, an overall increase in the incidence of CA over the 2-decade study period, from 0.88 per 100,000 person years to 3.56. So this was a significant increase in incidence over this time frame. And they also showed some differential effects by sex. So the rising incidence was primarily in the males in the cohort, which they interpreted as suggesting potentially a wild type transthyretin amyloidosis sort of etiology or mechanism. So this was very informative, having a population-based study to this scale, both in terms of tracking the sort of the temporal trends in the epidemiology, and then also pointing towards, some potential etiologic mechanistic hypotheses, which can then inform treatment trials. So this really has kind of led to a call to action for more of this research, of more population-based analyses. This is a Nature Genetics and Medicine an editorial that talks about the need for next generation public health response to rare diseases, and really involves kind of an embedded call to action for population-based work, and kind of federation and use of large databases to do this. And there was also at the EPA SCO Council meeting just last year in December of last year, so only a couple of months ago, there was a call to action as well on rare diseases from the Czech EU president, and 21 member states endorsed it. So there's more increasing awareness and recognition, and I think that some of the population-based work may have contributed to this call to action. But at the same time, so similar to some of the challenges that David just outlined with respect to clinical trials, really can this call to action be answered? So there are numerous challenges associated with conducting population-based analyses. Just like clinical trials, they're very costly and time-consuming for the prospective ascertainment when you're looking at rare diseases. There's a real lack of unique diagnostic coding in the administrative data. There's a kind of sparse data sources, inadequate data sources. There's a lack of validated case ascertainment algorithms, and then there's many analytic challenges and sort of statistical power challenges. So I'm going to talk a little bit about each of these in turn, and kind of some of the limitations and challenges, but also some of the ways in which, as I said, we're kind of innovating in this regard, and some of the progress that and opportunities that are now available. So as mentioned, the prospective design for population-based work is really it's a bit of a tough go for rare diseases. This study ascertained a cohort of 125 that was recruited over 18 years. So it just shows really how sort of time-consuming for very, very little yield in terms of statistical power this type of prospective work can be, and really how this can can really influence incidence estimates. So only losses of a few individuals from this can dramatically affect the calculated incidence rates. So I think that there's a consensus that prospective work is not the most appropriate for most rare diseases and cardiac diseases as well. There are relatively fewer prospective cohorts, and the case control study is an option when you want to do kind of population-based analyses or a retrospective cohort study for rare diseases and those with long latency periods. Point prevalence is the estimate that is the most appropriate if we want to look at that kind of population burden, as it provides a metric of that. And then, as just highlighted, there are multiple clinical trial designs which are a little bit more suited when the outcomes or the events or the cases themselves are very rare, such as crossover or adaptive trial designs. And I'll focus less on those because that was the topic of David's talk, but what I just wanted to mention as well. So in terms of the available data, there is a challenge with respect to the coding of these diseases. So as mentioned, there's almost 7,000 known rare diseases, but despite that, only about 500 are listed in the ICD-10. So in administrative coding and international classifications and health information systems, there's sort of scarce representation of some of these diseases, or they don't have a unique dedicated code. So of that, only about half have a specific diagnostic code. So that's a limitation on its own. And the result of this is that, as sort of highlighted in Andrew's talk, is that really the best sort of data source available is to develop registries. So I really loved Andrew's story about kind of trailblazing this 29 years ago, bringing together a few centers and starting to share data. I think that was, really the spirit of exactly, the kind of thing that's needed to develop these large scale registries. And I was really pleased to see how much it's grown. And this is exactly the type of thing that is really can enable these kinds of analyses due to the limitations of some of the administrative data. So there was actually a call from the World Economic Forum to do exactly that. So exactly what the Canadian group has been doing for some time. And this white paper was just published last year, Global Data Access for Solving Rare Disease. So it was a call as well to begin establishing sort of cross-jurisdictional federated data sources, so that involve linkage of multiple data types and sources across countries, and that this is really the way that we're going to be able to make gains and address some of the questions that are necessary for rare cardiac conditions. So especially this is important, as mentioned, in the context of now our ability to have genomic data, imaging analyses, multiple different types of data sources that we can then link and federate together into these kind of powerful data sources that really fully can characterize disease features and burden and progression in a way that we haven't really seen before. So as mentioned as well already, that there are some disease registries in place. So the OrphanNet is one that has kind of, as mentioned, really been sort of a flagship portal for rare diseases. And this is can be found at orpha.net. It's a 37-country network. This was co-funded by the European Commission. And the database is a comprehensive, manually curated, specific database that has expert review embedded, so that it's very high quality data. and it's been recognized as a valid and high quality resource as and both from the IRD IRC and Elixir Core Data Resource. So you can find out more information on their website, but and they have, as mentioned as well, a journal dedicated to rare diseases. So there's lots of information on that. In terms of cardiac registries, there's a recent systematic review published in 2021 in Insert Cardiovascular Quality that reviewed a number of national cardiac registries, 155 in fact, representing 49 countries and a total of over 70 million patients. So this was a very comprehensive systematic review. The registries involved are related to cardiac in general, so they're not dedicated rare cardiac condition registries, but many embed rare conditions within some of the 6 categories that are shown here. Enrollment in these registries was 60% procedure-based and 40% disease-based. And as you can see, most of them are related to coronary disease, or PCI, 28 to devices and arrhythmia and EP, 24 were related to heart failure and transplant mechanical support, 21 structural heart disease, 21 congenital, and also 16 related to cardiac surgery. So it's a very comprehensive review of all the kind of global national registries that are available. And I think it speaks to the infrastructure that the registry infrastructure that is available, within which I think there can be efforts to develop sort of sub-studies dedicated to rare cardiac conditions and kind of leverage that infrastructure that's already in place. So in this review, only 4 of the countries had comprehensive coverage of all of those 6 subspecialties. And then about 31% or 48 of the registries also were able to facilitate linkage to other population-based resources, such as the National Death Register or other administrative databases. So I think this is still something that's in development, obviously kind of globally. And, there's a hope from like the World Economic Forum indicated that there's a need to begin kind of wide, large-scale sharing of these data and linkage and federation, and so that we can get harmonized, standardized, and very high-quality data sources. Within these registries, the quality was a little bit variable. There was, of the total potential quality score, the median was 15, and cardiac surgery, although it was the smallest in terms of the number of registries, it had the highest quality score, and then it went down from there all the way to heart failure having the lowest quality score. So I think this is interesting in terms of showing where where some opportunities are for improvement in data quality and completeness, and also again just to kind of extend that hopefully to the rare disease setting. There are a real lack of validated algorithms, and this becomes really important when you're looking at rare diseases. And I'm going to talk a little bit about that in the context of some work that David and I are doing together, because it it ended up becoming a study that was necessary before we could do the study we wanted to do, because there was really no way to kind of ascertain validly the rare cases in the data. So there is this paper that was just published in Nature Science Reports that talks about the development and testing of diagnostic algorithms. And this little quote from there says, the identification of rare diseases in claims data remains challenging and really does require validated coding algorithms. So I think this is important when people are looking at the literature of rare diseases, really having a look at exactly how these data were identified and cases were identified, and whether or not a validated algorithm was used. Because I think that really speaks to the quality of the study and the interpretation that you can make from that, and really also quite affects the incidence and prevalence estimations, based on how things were defined. So we want to keep that in mind. As mentioned, David's work, which he reviewed really nicely in preparation for his clinical trial, one of the research questions of interest was to really try and characterize at a population level scale some of the environmental predictors of sarcoidosis. But when we went to embark on that, we quickly realized that there was really not a great algorithm for identifying the cardiac sarcoidosis in the administrative data. So what we did was we used his registry data, and this is another really good use for registry data. We were able to import that and link it with the broader population-based administrative data at ICES, and then develop a number of algorithms to test, and we were able to then validate a specific algorithm for cardiac sarcoidosis. So we linked the Ottawa Heart, the sarcoidosis registry, with the provincial data and developed 24 potential case definitions. So those were as broad as just having an outpatient encounter, which of course is going to be less sensitive and specifics, especially to having inpatient and then follow-up MRI or biopsy. So the algorithms varied very much in their composition, in the extent to which they integrated diagnostic sources, and also in their time frame, whether or not the diagnostic codes were available over a 6-month period or a year period. So due to the delays in the diagnosis and sort of the lengthy diagnostic process for many of these conditions, you have to really carefully consider in the algorithm what period in order to get accurate ascertainment over the full diagnostic window. So we developed 24 algorithms and tested actually only, I think, 8 or 9, but we did a full ROC AUC analysis to estimate the sensitivity and specificity of these algorithms. So these are data that are just in preparation for publication, and it's just, I won't go through them in detail, but you can just see over the various algorithms with this arrow how dramatically things dropped in terms of sensitivity and specificity depending on the case definition. So as mentioned before, in review of the literature, it's really important exactly what algorithm was used for the case definition, particularly in the setting of rare diseases, and whether or not you can really lose sensitivity and be subject to misclassification quite easily. So I want to finally move into some of the analytic challenges and statistical challenges with respect to power that's unfortunately rare diseases are a bit subject to. So one of the considerations, when you ascertain, your sample, whether it's case control or a cohort study, is whether or not that small sample that you're able to look at or have access to data to, whether they're representative of the entire population of patients. So there is sort of generalizability, external validity questions, around these small samples and their ability to represent the population. The very standard hypothesis testing methods that are often used, and p-values particularly, are quite vulnerable in the small sample size setting. And there was a nice illustrative example in this JAMA paper. It was published in 2020. They had one patient that was diagnosed with hyperthyroidism in a cohort of only 125 individuals. So they performed an exact test for one sample proportion, and the result of that was that there was no evidence that the estimated prevalence of the study population was different than the general population. So their p-value was 0.88. But if as a little bit of an exercise, you adjust the sample proportion test. So if 2 patients were ascertained instead of 1, the p-value would have gone to 0.23. And if 3 were diagnosed, it would have been 0.04. So you can see how really very small numbers can really swing hypothesis testing and p-values, and impact the estimates that then potentially had implications in terms of decision making for these patients. So it can be quite statistically challenging to have confidence in your estimates. And for that reason, if you're going to undertake population-based analyses and do outcome assessment, when often in rare disease cases, outcomes are also quite rare. So Poisson regression is really recommended as the appropriate statistic for analyzing rare events when subjects are followed over time. But where they are subject to some issues when they're applied to binomial data, sometimes the estimated relative risk can be overestimated. But but there's lots of methods to kind of mitigate this, and using what's known as a sandwich estimator for variance, a robust estimator to kind of account for this overestimation, can correct for that. So I think it's important to have considerations of the use of different analytic strategies that are most appropriate when you know you're in a rare disease setting and you're going to have a small sample size, and then particularly appropriate for David's clinical trial and other trials, particularly adaptive clinical trial designs. Bayesian strategies are becoming more and more common as the approach in an adaptive trial setting. So some key messages in terms of doing population-based analyses and work for rare cardiac diseases. Due to their very high population prevalence and significant burden for patients and caregivers, I think that population studies are really critically important for both raising awareness of rare diseases, documenting temporal and epidemiologic trends, and identifying patient characteristics, and then informing things like potential treatment response that can then be used hopefully in some of these clinical trials. Just like the clinical trials, there are several challenges that exist with validity and availability of data in the setting of rare diseases, but I think there is sort of hope and a lot of advances that have been happening more recently with regard to federating multiple data sources, linking them, and sharing some of these registries, and hopefully with some of the global infrastructure that's in place for more major cardiac registries, we can also then begin to build more infrastructure for dedicated rare disease registries as well. And I think it's very important to be mindful in both the interpretation of and the conduct of population-based analyses to be very careful about your study design and analytic approach, so that you can mitigate some of the potential biases that impact the analysis of rare outcomes and the use of small sample sizes. But there are lots of methods available, and so I think it's just important to be mindful of the best approach and use those validated algorithms when you can. So very kind of appropriately, coming up on Tuesday next week is Rare Disease Day. And on February 28th. And so it was my real pleasure to present today on this and a little bit of insights into how to do population-based analyses in the setting of rare cardiac diseases. And I thank you for your attention.
Thanks, Jodie. That was outstanding, really fascinating and tremendous. And thanks for highlighting Rare Diseases Day. It's no coincidence that our conference was timed quite close to that date, and thanks to Andrew Crean, actually, who pointed that out, that it was Rare Diseases Day next week, and that's why we timed our conference to be almost exactly the same day. So we will open it up to a panel discussion. So if anybody has any questions, please put it in the chat, raise your hand, question and answers as well. I'm maybe going to take Chairman's privilege here and ask the first question of Andrew. So, one of the hopes of this conference is that we're going to hopefully birth lots of national networks and lots of rare diseases. Some already have nascent networks, but are I hope we can help them to grow. So my question for you, Andrew, is with the benefit of hindsight, what would you have done different? What were your top 3 mistakes that you made? And what can you teach us there?
Well, it's a very good question. So one of the things I didn't talk about in any detail is that even though you might argue that, the notion of identifying what you want to do and then studying it prospectively, you would think that would create a very high level of data, and that very high level of data would give you a very perfect and robust description of the disease and its progression and treatment, diagnosis, etc. But one of the things that happens, the reality is that we are essentially functionally collecting clinical data, and that clinical data is collected in a variable way across our health record and health system, and then it's entered in a variable way. and some of the discipline to create standardization of process to make sure, like Jody commented on too, about what you when you say that a patient has a QT interval or a heart rate or a family history of sudden death or some parameter like that. And so what you end up doing is when you do research projects on these prospective registries, then you understand the limitations of your data set, because you start to realize that data is incomplete or that it's not articulated clearly and so on. So one might argue that the future will help with that problem or mistake that was made was to take the time and have the discipline to create a more robust data set and definitions along the way to create more a better system. That our future data systems will be better because of all of the capability of our computational capabilities and so on. But at the same time, I'll just be a little cynical and say, you'd have thought that a robust, properly functioning electronic health record connected across Canada for us to be able to study rare diseases would be a no-brainer. But we're proving how profoundly stupid and incapable we are of executing that, despite the logic, And so I might argue maybe one of the mistakes that was made was not having either the capability or the foresight to try to create a platform or system upon which we would have a better ability to detect and then study health issues, in particular rare diseases, because they really need to be connected across our system to understand and manage them better. I know that's not 3 answers, David, but I think one of the frustrations is that it's still so dependent on variable quality of the inputs, and as a result, the outputs are not as good as they could be.
Yeah, no, that's an excellent answer. I'm going to answer my own question, because one of the mistakes I made when I set up the registry early on in cardiac sarcoidosis was asking for far too much data, and the data quality is inversely proportional to the data quantity. So one of the keys that I learned from Andrea also was, rather than ask sites to do lots of manual data entry, just ask them to upload the de-identified PDF of the ECG, and we'll abstract the data for you, and so on and so forth. So that was one key thing. So I'm seeing lots of questions coming in. So I'm not sure what order. Actually, I think Gavin put his hand up first. So Gavin Udet, you're muted. Are you able to unmute yourself, or?
Yeah, I'm good now.
Okay.
Yeah, great. Yeah, thank you very much. It was a great conference. Start off for this, and so just a quick question about how embedded are we in AI and machine learning as we deal with data extraction. You've talked about PDF. You've talked about understanding a relatively rare condition in the setting of common disease, and so looking at more complicated analytics such as AI and machine learning, is that something that we're looking at building into look at the platforms, the research programs that we're establishing?
Well, maybe I'll start by answering. So on the one hand, as David said, it's about 7 or 8 years ago, I sort of had the brainwave that when we looked at data, one of the mechanisms to improve it was to get source data. And it's sort of like a data core lab concept, not quite in the same way that you enterprise the payment to have structured interpretation of things where a single imaging lab, for example, takes the same approach. But the whole idea that, so for instance, we have more than 30,000 documents in HERO. And most of them are ECGs, Holters, stress tests, those kinds of things, and imaging reports. And we have capability for DICOM upload for echoes and MRIs. And we've started down the path of trying to look at AI and machine learning for analysis. And there are some exciting preliminary things that happen, in part because AI and machine learning should be able to also take unstructured data and provide some structure to it as well, right? So
Yeah.
yes, on the one hand, the flip side is most of the information that all the data systems are looking for are already exist, and they're compartmentalized in our dysfunctional system.
Yeah.
So you know, in a way, we need a privacy officer more than we need a research officer.
Yeah, because one of the common things we see as we all treating these patients is misdiagnosis, right? Very common with rare conditions. And so sarcoidosis, Fabry's, I mean, we can go on. And so it's something in the imaging or something in the ECG that we just glanced over and it was missed. And so we see these patients show up 10, 20 years later and they're quite advanced. So those are the kind of things that we want to, put in place so we can pick up these, rarer diagnosis much earlier. And because as we now have precision medicine specific therapies, this is something that really should be a top priority for us to do. Thank you.
I'll just follow up quickly, David, on that. Just from my perspective, in terms of conducting kind of larger population-based analyses, I think Gavin's correct in that there's applications of machine learning techniques for classification problems and in kind of managing some of the many data sources we have, diagnostics, just like Andrew was talking about. But from my perspective, when you're trying to do more, prognostic analyses, develop certain prediction models for longer term outcomes, there's less of a role. It's a more challenging problem to apply. From my perspective, to a machine learning setting, they don't accommodate things like competing risks, time varying treatment allocations, those types of things, as well as some of the other methods for development of prediction models. And that's certainly kind of, I know there's multiple camps on that, but that's one consideration from my perspective.
Yeah, so lots of hands up. So next in order is Ian Patterson.
Thank you very much. Very much enjoyed everyone's talk this morning. I was just curious to know, you guys talked about how long it took to develop these networks. I think about Gavin, who just spoke. Gavin has recently received funding from Heart and Stroke to start a neuromuscular disease network. So that, he's potentially looking at a similar journey to what was just described. So are there ways to accelerate the growth of these new networks? Are there linkages that are being formed between these rare networks? So, are you helping the networks that are just starting, and the ones who are established, are you performing linkages with one another to develop best practices, for example?
I can maybe answer that. The short answer is only informally. Again, it's one of the hopes of this conference that this is the start of a more formal process to help each other. And I think even by having this conference, will help grant applications going forward, and we can perhaps even talk about an even more formal structure for this network of networks, if you like. But the informal advice is very important. I took lots of advice from Andrew as I wrote my grant. I'm happy to give advice to others as they come on board. In my grant applications, I cited Andrew's successes as part of the reason for the rationale behind funding me. So, yeah, great question, Ian. The others, Andrew, do you have any comments, Jody?
Yeah, I guess what I would add is I think David makes a very good point, which is precedent makes all the difference in the world, because once you establish that it's feasible, then the question is how to assemble the people and get enthusiasm. As you know, in research, I think it's just fair to say that all processes require a champion, and people have to sort of have conviction. They don't do things because they should or and so on. So they have to kind of take ownership of the research question. So, what you'll find most of the time, and we've certainly found this, like with 24 centers, what I would say is, like most human experiments, a quarter of the people probably do 3/4 of the work in terms of the enrollment, the energy, the project proposals, those aspects of things. We felt it's important to kind of have a national profile, and so we've been very inclusive, including sites that don't do a lot of the work. But the principle of saying, anyone can come in the tent, and we want to work on this together as long as there's a group of champions to advance it. So I guess I would say that if somebody has the idea and they're formulating this, or for Gavin, for instance, I would say, find yourself that, if you like, inner circle of people who are really going to push this out of the gate. And once there's some momentum, then people will join into that to try to help understand this, and because they also want some context or family within which to put their experience with the rare condition.
So 2 more questions, Christopher McMaster and then Rob Beanlands after.
Hi, thanks. I'm Chris McMaster. I'm the Scientific Director for CIHR's Institute of Genetics. That's half my life. The other half is I'm a professor of pharmacology at Dalhousie University. This is with my potential funders hat on. In terms of diagnosis of rare cardiac diseases, would it be helpful, and these are things we're thinking about, and England is a little farther ahead, but thinking about genomics at birth? Or right now, genomics tends to be a test that's ordered by a sub-specialist who's a rare disease person or medical geneticist. So should we try and move genomics to very early in the care pathway, considering it's not a very expensive test anymore? And if we do that, wouldn't it make sense then to patch on ORFA-codes, which is a patch for ICD coding that contains every orphan disease, all 7,000 right now. So then you could actually move prospectively versus, single point or retrospective studies, which are not as accurate and much more of a pain in the butt to do. So just thoughts on those ideas.
Well, I can talk about this until it's summer. So I think the short answer is that it's a little bit like Moore's law and computational capability. The cost, access, and scope of genetic testing is just moving so quickly that there are conversations about the $100 and $200 genome. That's what it costs to say hello to the triage nurse in the emergency room, right? So cost is really functionally not an issue. It's more a matter of capability, utility, and implications. And so I think that the government or funder struggle is that that small proportion of our DNA that's variable is very heterogeneous. It's probably fairly ethnic specific. And the implications of it are difficult to understand other than answering the question, what does it all mean? And so the funder has to have that vision without having a question to answer or a hypothesis like we do in a traditional scientific way. And so a good example is, a good guesstimate is that we all harbor about 5 or 6 what appear to be apparently fatal inherited genetic findings that don't get us. Something else that we don't understand in our genetic center environment is protecting us from those fatal things that should cause premature, cardiac disease and cancer and all these other aspects of things. And so then what to do with that information and how to track it is useful. And the other thing is, we are ethically, culturally, spiritually, completely unprepared for that question. And no one is really owning the question about the stewardship of the data, the implications, the utilization, and so on. And the slope to the potential interest in genetic engineering is another major hurdle culturally and societally that we don't have a good sense of, because the utilization of that information can lead to so much potential governance, ethical considerations. So I could talk about this a lot, but I think the point is we definitely should. I can show you a slide from 20 years ago, and I said, to the ministry in Ontario, this is what you should be doing. It's the heel prick at birth that we've all been doing forever. But it has to be linked to data, and there has to be an oversight process. And you're right, the UK is ahead of us on this.
Peter, are there efforts by patient groups or foundations to help to either fundraise or lobby for vendor funding? MS and muscular dystrophy groups have been very successful. I can speak briefly about what's happening in sarcoidosis. So there's a very active group in Europe. There's a very active group in the US. The US group is a little bit active in Canada that mostly don't do a lot of lobbying, but are very successful at fundraising. and disperse substantial amounts of money for research. I don't think they do a whole lot of lobbying, though. Andrew, you have a pretty active patient group.
Yeah, I would say same kind of thing, where their primary goal is essentially education and support, and not as much advocacy and lobbying. So you know, they're very keen on from an agenda perspective, understanding the experience, living with it, mitigating risk, and so on. Less on the discovery part of things. Our neck of the woods is now on the brink of gene therapy, which is a pretty you know, game-changing kind of approach to this. That's probably you know, we're in the toe in the water phase right now. 3 to 5 years from now, I expect we'll be either doing formal clinical trials or implementing it clinically. So, I mean, that's pretty radical, and it's a really rewarding end of career for me to be working in that space when that kind of thing can happen. And patients are very excited, but they're not. But we haven't yet arrived at a federal lobby. The federal lobby has actually been around population management for things like AED training and prevention mechanisms. So, you know, syncope awareness. There's been, you know, formal provincial level legislation in a number of different environments about, you know, you shouldn't have a driver's license without learning how to do resuscitation. Yeah. I fully agree. Those kinds of things, but not as much around access to rare and expensive drugs. Just happens not to be the case for us at this point yet.
Yeah, I would follow up, David, and with your work, I would say there was a real role for patient groups potentially in when you noted that there was a real gap in terms of what the treatment goals were. And so I think that there would be a you know, a real role for a patient-oriented effort for that.
Another question from Peter in the chat, and then we'll go to Rob after that. Could one consider adaptive designs for rare cardiac disease? We've been trying this for long COVID. Yeah, no, Peter, actually, I probably should have had a slide on that. If anybody wants it, there's a very good paper, a very good review article that I read that said something like the top 7 clinical trial designs for rare cardiac diseases, and goes through the pros and cons of each of them, and some very cool trial designs, including, you know, yeah, some very cool trial designs. So Dr. Beanlands.
Yes, thank you. What a great session, and thank you guys. Thank everybody for organizing this. Really putting it out there and timely with the Rare Diseases Day next week, which I didn't know about, but we'll try to celebrate. So 2 questions there, a little bit dovetailing what others have already asked. So Gavin asked about the diagnosis, and, you know, really imaging is so critical to many of the diagnoses, and kind of maybe a question for Jody, like how to integrate that into the diagnosis and the diagnostic certainty in terms of, you know, tapping the data. And, you know, to David's point, like when you're setting up a registry, it's maybe not being so specific about gathering data. However, the offset of that is, are you actually really detecting the disease in all the patients? So to kind of make that point. And then the other is, you know, in addition to what Peter asked about lobbying, like I know Andrew's been obviously successful, and David, you've been successful with registries getting CIHR to fund them, but really it's a tough sell to CIHR. Are there other avenues for trying to get funding to set up registries for these rare diseases? So 2 questions.
So to speak to the first with respect to the imaging, I think what's critically important, as you mentioned, is just what David and I's approach was to embed imaging as part of the validation algorithm. I think that's a really crucial thing. And so then when you are looking at, different studies and if they've used a validated algorithm, I think that those ones that might have, if imaging really is critical to the exclusion of other diagnoses, which could lead to that misclassification, then I think those algorithms are going to be the ones that produce higher quality estimates. So. And then, of course, with federating the data sources, we need to have imaging as a core feature of that, the large standardized data sets.
Thanks, Jody.
Yeah, I can maybe answer the funding question, Rob. When I was working on my grant for cardiac sarcoidosis, a number of people said to me, no point in even applying. CHR never funds registries. So I thought, well, maybe one of the tricks I tried was I decided to call it a prospective cohort study. I didn't mention the word registry anywhere in my grant.
Yes.
And anyway, it got funded, and it's been proven. The CHR is now funded multiple registry. They funded SCAD registry. They funded heart stroke. So, I think that old teaching that they never fund registries is well and truly over.
That's good. That's good.
Yeah, Rob, I'll be a little counterpoint to David and say I think the same advice I gave him is something I learned the hard way, which is if you say you're proposing a database or a registry, everybody wants data. And so they're not doing that. They're actually funding studies where questions are being answered. So
Right.
The registry is the byproduct of answering 3 important questions, like what is it, how do I diagnose it, how do I treat it, or whatever those questions are. But what they've seen is that, we now understand these conditions and have better ways to do this through basically ROI on doing this in the past. So,
Yeah.
so I that's why David didn't use the word registry, right?
Yeah. Yeah.
Very smart. I think the other 2 instances to draw on, I'll take an analogy of a friend of mine was in a very large law firm, and one of the senior people, by sheer coincidence, had detection of a mass in his abdomen by a CT scan. And the whole company took up a multi-million-dollar executive health screening strategy because of one incident, because it had a profound effect on the individual. So, and that sort of resonates also with the concept of either corporate or profoundly affected donors who can say, I don't want other families to go through what I've been through, or other people who suffered this tragedy or something like that, and translate that care experience of a rare disease into a platform for understanding and treating it better. So, and healthcare workers are actually not terribly adept at recognizing that opportunity. And as a leader, that we need to be for us to be able to do better.
Yeah, certainly the amyloidosis world has enabled that strategy well. Many amyloid centers are funded by individuals who've been affected, for sure. That's a great point. Thanks both. Thanks all. Great session.
And we're almost out of time. There's a comment in the chat here from Julie Richera. In the aortopathy world, the Lois Detz Foundation, started by patients, starting to fundraise, add-on special days to educate MDs, and launching a program of small grants in the last year. So it is happening, which is great to hear. I maybe just ask one final question, and it's a question to Jody, actually. I had no idea that the ICD coding was so poor for rare diseases, and you said that only 250 out of 7,000 have got ICD specific coding. Can you, my question is, can you estimate or imagine how many of the other diseases could be accurately identified using an algorithmic approach like we've done for cardiac sarcoidosis?
Probably, I couldn't do it off the top of my head, I don't think. I mean, it depends on many things, like exactly how patients encounter, how they interact with the health system to encounter the diagnosis. And like when we were building our algorithms, I had so many questions about how the patient's pathway. And so I think if there is a relatively clear-cut pathway where we could pull, you know, specific things like procedures or even medication usage, depending on, you know, on if we could have access to that, then you know, you'd have a higher proportion that could be ascertained. But if it's one of these things where you know, they kind of float around in the outpatient world for a long time, and then I think it can be really challenging. But I know Dr. McMaster has talked here about these ORFA codes as well, and that they are much more comprehensive in terms of the rare diseases. But in my experience, they're much less utilized as well. Most people, you know, do rely on more the ICD, the standard ICD-10 coding. So maybe if there was a little bit more of an effort to try and, you know, to encourage utilization of the ORFA codes and more access to that, that could probably be very helpful.
Okay, thank you. Okay, well, that's the end of the first session. So everybody gets a break now, and we reconvene at 10:30. Thanks, especially to our two speakers. That was really an outstanding start to the day. Thank you.
For the rest of these plenary talks, we're going to follow the same format. So we have three exciting speakers who are going to speak, and then there'll be a question period afterwards. So I'd ask you to please hold to the end. And again, as before, you can type questions in the chat, even as the talks are going on. We'll get to them during the discussion panel period. Or you can wait to raise your hand virtually at the end. For the first talk for the second session, I'm going to introduce my friend and colleague, Dr. Gavin Udet. Gavin and I worked together for many years at the Mazankowski Alberta Heart Institute. He's a professor of medicine, staff cardiologist and clinician scientist, and a lot of his work has been around heart failure and cardiomyopathies. He holds a Canada Research Chair in heart failure. He's the director of the Heart Function Clinic. He's a fellow of the Canadian Academy of Health Sciences. And, you know, Gavin is involved with a lot of things, but I thought it would be very helpful to hear from him about some of the work he's done in neuromuscular disease related work, especially as it pertains to preclinical and translational models, which is an area that I think it would, you know, we need expertise in, especially when it comes to rare diseases. And then Gavin also, I mentioned earlier, recently got some funding to lead a clinical national registry on neuromuscular disease cardiomyopathies as well. And so he's really doing the full spectrum from bench to bedside. So with that, Gavin, welcome, and look forward to hearing your presentation.
Great. Thank you very much, Ian. Yeah, thank you for the invitation, and great to be here. And yeah, I do cherish the moments we worked together here in Edmonton, and looking forward to continue working with you and your team there in Ottawa. So I've been tasked to talk about some of the preclinical and translational studies. And, you know, I kind of want to sort of really get into making the case for precision medicine for cardiomyopathy. So, you know, we've talked so much about it in the last few decades. It's time for action. It's time to see what exactly we're doing. And I'll provide some insight in terms of preclinical and some of the translational studies that we're doing in terms of bringing that to rare diseases and cardiomyopathies associated with those conditions. So those are my disclosures. So this is a seminal paper. I think David talked about this briefly. This is Michael Felker work back now over 2 decades ago. And as you can see, you know, this is outcomes in patients with, I think, 1,300 patients with cardiomyopathies, and showing that the dilated cardiomyopathies did poorly, but not as bad as the infiltrative myocardial disease. So things like sarcoid, amyloid, iron overload cardiomyopathy. So that's a take-home message there, that these types of infiltrative cardiomyopathies do poorly. Things have changed. The outcomes are a lot better now, as you've heard from David, with sarcoidosis. We see it now with iron overload, with amyloid, as Ian will show later on. So things have changed, but the traditional state is that these conditions are have very poor prognosis. And it goes to the point of making the diagnosis early because we now have therapy. So diagnosis here is very critical. So understanding cardiomyopathies and rare conditions. So we've talked a lot. Jody spoke a lot about registry, and Andrew and Jody spoke about registries, cohorts, looking at outcomes data and so on, and that's all fabulous and absolutely critical. What is also important is tissues and biomarkers. And so one of the programs we set up here at the Mazankowski Alberta Heart Institute is the Explanted Heart program. And these are numbers at the top there. We collect all adult hearts, pediatric hearts, LVAD cores, and healthy control hearts. You can see the etiology shown there, lots of dilated cardiomyopathy, but also other types of cardiomyopathies, hypertrophic cardiomyopathies, a few sarcoidosis, and other types of congenital heart disease and so on. And so with this tissue collection and with the clinical data, which is very extensive, we're now able to analyze this tissue at a very detailed level. And this is one of the many reasons for creating a biorepository of plasma, urine, and tissue, is that when we started this 15 years ago, in fact, we didn't have very, very complicated techniques to look at this. This has all changed in the last 15 years. We now have extensive proteomics, metabolomics, single nuke RNA-seq that are very, very detailed and revealing. And so we're able to put through our tissues through those protocols. And in fact, you know, this is part of foresight in being able to collect and build a tissue repository of samples. I think plasma and urine we have from other cores, but the tissue was very important. And, you know, we have one of the largest transplant program here in Edmonton. So this was a great opportunity. One of the first things we learned, and this is shown on the right, bottom right there, is that the heart is made up of at least 8 different cells. So you have cardiomyocytes, you have endothelial cells, fibroblasts, pericytes, neuronal cells, adipocytes, lymphoid, and myeloid cells. Those are inflammatory cells. So it's not all muscle, it's not all cardiomyocytes. So those cell types are very critical. They're involved in remodeling the heart in all types of disease, rare disease, common disease. They're critical. So that's was part of our humbling experience in learning about the adult heart. The next thing we did was to look at how things change in cardiomyopathy. So this is shown in the top there. We looked at controls, dilated arrhythmogenic cardiomyopathies. We studied an extensive number of mutations in these hearts. So these are shown in the middle panel there. So the titin, the lamin, some of the RB20, and other types of mutations that leads to dilated cardiomyopathy and arrhythmogenic cardiomyopathy. We're able to confirm all of those different cell types. We looked at the RV, the LV, so we looked at chamber-specific remodeling. And the fabulous data is actually shown, very, very small fraction of the data is shown on the right. And so it's a bit of a picture representation of the data. So I'll just go through it, and you know, we don't have time to go through all of it, but you can see the cell types are listed on the left. And you can see in the different types, so the brown is an increase, the blue is a decrease. So you can start to realize that in different types of cardiomyopathies, those cell types are changing in different proportion. And so, yes, you get a loss of cardiomyocytes, you get a small increase in fibroblasts, you also get an expansion of the inflammatory cells. And so that's a very interesting finding, especially in the PV negative case. So as you know, genetic testing only show a pathogenic or likely pathogenic variant in about 1/3 of cardiomyopathy. So most of these are still PV negative, pathogenic variant negative, but the dominant signature there in these hearts is actually an increase in inflammatory cells. Is this post-viral myocarditis? Is this autoimmune myocarditis? So very intriguing questions, and you know, we're very happy to publish this with our colleagues. This is part of an international collaboration. I think Andrew spoke and David spoke a lot about this. You got to connect with people. There's no way we would be able to do the single nuke RNA-seq here in Edmonton, and even most centers in Canada would struggle with this volume of work. The supplemental data for this publication, which came out in Science about 6 months ago, the supplemental data took 8 hours to upload. So it's that massive volume of data. And I say that only to emphasize the importance of collaborating with experts. So we were fortunate to collaborate with the Cambridge Group, the Sanger Center, and the Broad Institute in Boston and Harvard. So the two world's leading authorities on genetics and cardiomyopathies. And so we, of course, what we brought was a lot of samples, clinical data, and that we were able to work together as a team. So that's very important. The other thing we did was to look at explanted heart samples and look at what the diagnosis is. And so here, this is a graphic representation of that, tabular representation of the data. So the number one variant here in the dilated cardiomyopathy is the Titin, followed by the Lamin and the BAC3. Now, the Titin cardiomyopathy is a much more milder type of cardiomyopathy. They can be severe, but they're really bad ones for dilated. So the Lamins and the BAC3, and we have one of the largest cohort here in Canada of BAC3 patients with BAC3 mutations. And so those were very important findings. The table on the right is equally important because we showed, and it's much higher than what we see clinically, we are able to detect about 40 to 50% of our cases as a pathogenic variant. So this is important. So patients that progress to end stage have more of a pathogenic, a genotype positive pathophysiology than someone who's PV negative. So clinically, you get about 20 to 30% pickup rate. When you look at the tissue, you actually go to 40 to 50% of those detection rates. So a lot higher, and so very interesting finding that we're about to publish. Very exciting. This is one of the reasons why we do research. And we're able to find 3 very unique cardiomyopathies. One is a very large deletion in the Titin gene, leading to cardiomyopathy. One was a BAC3 mutation from a family that's outside of Alberta. And one that's probably the most fascinating is actually a patient that was missed with Duchenne cardiomyopathy, Duchenne muscular dystrophy, with a very large deletion mutation in the gene. I'll talk a lot about Duchenne muscular dystrophy later on. So quite fascinating. And this is a patient that struggled as a child with exercise, struggled with weakness, that people thought it was all from his heart, but it's actually muscular dystrophy. So it was a misdiagnosis that we detected on an explanted heart sample. So that's not how we should be doing things, but and it goes to show why we need to look closely at what we're doing. We were able to pick up myocarditis too in these samples. This is a positive, a genotype negative case that had parvovirus. So the parvovirus infects the endothelial cells in the heart predominantly. They get into the genome, and so by doing whole genome sequencing, so not panel-based testing or whole exome sequencing, it would miss this. Whole genome sequencing, we're able to pick up parvovirus, positive cardiac MRI in retrospect, and histological findings of infiltration here by macrophages. So CD68 positive in both an adult case and in the pediatric case with increased H&E positive cells shown here. So a very interesting case, again, ongoing myocarditis that was not necessarily well diagnosed clinically. So this actually has allowed us to build a cardiomyopathy clinic. We have now recruited just under 400 patients in this clinic, and it's from a whole series of colleagues shown in the top left, the muscular dystrophy clinic, the pediatric cardiomyopathy clinic, friends and colleagues outside of Edmonton, the medical examiner office. So we have a program where we look at patients that die unexpectedly. We're able to now study those patients, and referrals from our wonderful colleagues in medical genetics that are able to support this. And as you can see, the program, they've detected a lot of cardiomyopathies and a lot of infiltrative cardiomyopathies too that have been missed. So this is our program. It's growing. We screen family members and so on. So quite an interesting that we're able to now translate those tissue-based findings now back into a clinic. And so I'll show you some examples of work with Fabry disease and an iron overload cardiomyopathy and muscular dystrophy as we progress here. So jumping into the restrictive cardiomyopathy, so this is one way of looking at some of these rare cardiomyopathies. So amyloidosis is probably the best example. Sarcoid can also do it, and so is Fabry's disease and iron overload. So I'll be speaking about Fabry's disease and iron overload cardiomyopathy, and then finish up with some work we're doing with Duchenne muscular dystrophy. So Fabry's disease is a metabolic disorder. It's a systemic disorder in which the heart is predominantly affected, the heart and kidneys. Heart disease now is the #1 contributor to mortality and morbidity in these patients. It's due to an enzyme deficiency, alpha-galactosidase enzyme that breaks down that terminal galactosidase residue from the single lipid. So this leads to accumulation in the heart, it leads to hypertrophy, it leads to conduction disease and bradyarrhythmias. It also leads to hypertrophy and valvular heart disease. So this is something we've been working on now for over a decade, and we've done a lot of important work here with Ian when he was here in terms of using imaging to detect Fabry's disease and the value of T1 mapping. So the mouse model has been very insightful in discovering new therapies for Fabry's disease. This is on the left. You can see substrate reduction therapy. So what you're trying to do here, you're trying to, back to this previous slide, you're trying to reduce the formation of the glycosphingolipid. So it's a very upstream pathway. This is now in phase 3 trial, which we are part of. Some of that data from the animal model is shown at the bottom there. You can see with reduction in the GL3, the single lipid accumulation in tissue, when you add substrate reduction therapy in addition to enzyme replacement therapy. So the enzyme replacement therapy is just giving back the recombinant enzyme. The substrate reduction therapy is trying to prevent that formation of the glycosphingolipid. The other way in which this is being tackled is using viral therapy, lentiviral therapy, that's been used successfully with Jeff Medin's group, that has made it into phase 1 clinical trial with very interesting findings. And this is was also tested in this Fabry's disease mouse model, and has now actually made it into clinical trial and is progressing. So this is giving back in the bone marrow cells, transfecting them using lentivirus, giving back the enzyme, and then doing a less than aggressive version of a bone marrow transplant. So giving them back the gene in the bone marrow cells with very successful results. So very exciting biochemical and genetic approaches to Fabry's disease. And, 3 decades ago, we had nothing. If I had to show you this slide, there was absolutely nothing on this slide. This is the current state of therapies for Fabry's disease. Shown on the right there, you can see the gene going all the way to the lipid. So most of our therapy is enzyme replacement therapy. You see in the bottom right, the 2 versions of it. They do make a difference for patients, especially when started early. So importantly, early diagnosis is very important. Imaging and clinical acumen is critically important. Not just imaging, we tend to forget our clinical skills when we're dealing with these patients. So you always got to stand back and look at the big picture when we're dealing with undiagnosed cardiomyopathy. So enzyme replacement therapy is current therapy. We now have chaperone therapy, where we can take the enzyme that's sluggish in terms of from the enzyme from the ER into the lysosome. So that's chaperone therapy. 2 major classes of therapies now for Fabry's disease. We've talked about substrate reduction therapy, shown on the left, and that's now moving into phase 3 trial. And then, of course, we've talked about the lentivirus and gene therapy that's also moving into clinical trials. So 2 different approved therapies, 2 that are already in clinical trials. Amazing. In a few decades, we went from 0 to 2 types of therapies in clinical use and 2 that are in clinical trials. So that is the progression that we're seeing in genetics and molecular therapy. So it's quite exciting time to be doing this. So I just want to highlight how much impact we have had on Fabry's disease. So the other condition we have studied is iron overload cardiomyopathy. I'm sure Peter Liu would remember this well. He was one of my co-mentors in Toronto when we started this work. And so the iron overload cardiomyopathy is very interesting, because why would iron overload injure the heart? And so we don't quite, we struggle with that question. So iron overload cardiomyopathy is a major problem for patients with primary hemochromatosis, the most common genetic disorder in Caucasians and in patients with secondary iron overload from blood transfusions, the most common genetic disorder worldwide due to thalassemia and sickle cell anemia. So these are actually serious conditions on a worldwide basis. We may not see a lot of it here in Canada, but it's important. So we tried to answer the question. I don't have the time to go through all of it, but why do patients get iron overload cardiomyopathy? And so we show that the L-type calcium channel is actually a bit promiscuous, and it allows not only calcium to enter the heart, but also allows iron. So this is a study we did now quite over 2 decades ago as part of my PhD, where we showed that we can block the intracellular accumulation of iron. So that's the Prussian blue staining you're seeing here. You can see all the blue staining within the cardiomyocytes are dramatically reduced by calcium channel blockers. The extracellular accumulation of iron remains unchanged. So quite striking finding that we're able to publish in Nature Medicine. And then we took this into a different animal model, a model of primary hemochromatosis, aging these mice to 12 months and showing that amlodipine actually prevents iron overload in this model also. You can see the Prussian blue staining there in the second panel reduced with amlodipine. We isolated cardiomyocytes from these hearts and showed that we can rescue contractility shown in A, and then also improve calcium cycling. These are defective calcium cycling is a hallmark feature of cardiomyopathies. We're able to rescue, not prevent these types of changes in these hearts. We also show several of the molecular changes such as downregulation of SERCA, upregulation of the sodium calcium exchanger that you typically get with cardiomyopathies, all of which was rescued by amlodipine therapy for 3 months. This is actually a tissue we took out from a patient with iron overload cardiomyopathy that went for transplant, someone with beta thalassemia major. And you can see what's beautiful here is that you can see the iron deposition here in the heart, NMR spectroscopy confirming iron deposition in the heart in addition to the EM. But very importantly, the molecular changes that we're seeing in these hearts were identical to what we saw in our mouse model. So just a beautiful demonstration of why you need to collect human tissues and human biomarkers. It really helps with the preclinical model, the mouse model, and trying to elucidate therapies and the impact of calcium channel blockers. So since then, I have been able to put 3 patients on amlodipine for iron overload cardiomyopathies, and they have done very well. This has actually made it into phase 2 clinical trial, showing that amlodipine does reduce the myocardial iron uptake in the heart. A small trial, a larger trial, showing that it does improve myocardial iron deposition in the heart. So this is, of course, using the T2 star, going back to that image. So the lower the T2 star, higher the iron level is. So you can see the inverse drop in here, the increase in the T2 value, suggesting that there's a reduction in iron overload. So this has actually moved into clinical trials. And it's also important because amlodipine is very safe in children, so you can use this at a very early stage. And this was planned for actually moving into phase 3 trial. One of the things that have changed the course of this is actually CRISPR-Cas. And so beautiful data that's shown that you can now correct hemoglobin mutations. So thalassemia, sickle cell anemia, with CRISPR-Cas technology, and patients were able to receive this therapy, correct their anemia. They're no longer needing blood transfusions. I'm happy to be undone by the progress in molecular medicine, but that's the therapy you want, CRISPR-Cas. It probably will win the Nobel Prize in a few years, but this is absolutely fabulous because you're going to have such a global impact here from CRISPR-Cas by correcting those hemoglobin defects that are triggering these anemias. So these patients now, 3 years in, do not need any blood transfusions. So it's going to have a huge impact on iron overload cardiomyopathy. Okay, so the progression here in molecular therapies and genetic medicine is just phenomenal. So I continue to use amlodipine in patients with iron overload. That, of course, the CRISPR-Cas is not clinically indicated yet, so it's still in trials, but the data is very exciting. So, so that's our story with iron overload cardiomyopathy. our major program right now is actually in muscular dystrophy. So as Ian indicated, we do have a grant to maintain our registry, but we have teamed up with colleagues to really understand this disease at a molecular level. So this is a horrible disease, absolutely horrible disease. And it's one of the reasons why we joined the muscular dystrophy clinic. We came together as a team. I'll talk about this in the afternoon. We came together as a team with neurology, respirology, physiatry, and cardiology, with social worker and nurses to help these patients. And so the group of patients that struggle the most is patients with Duchenne muscular dystrophy. So it's an excellent progressive disease. Patients would die as teenagers, adolescents. They now live into their 30s, but they still die so prematurely, and it's often a terrible quality of life, and it's most of these patients are wheelchair bound. The predominant cardiac finding, the dystrophin gene, of course, is a sarcolemmal protein that allows the matrix to connect to the heart, which is critical in all striated muscle, including the heart, diaphragm, and skeletal muscle, and the respiratory muscle. So those are the predominant manifestations of Duchenne muscular dystrophy. And there's a lot of fibrosis and cardiomyopathy in these patients. So animal models. So we're thinking about, we need models, we need tissues to better understand and treat this disease. Animal models here are challenging because they don't always simulate what we see in the patients. In fact, some of the early knockout mice of the muscular dystrophy gene actually just has a very mild phenotype. There is a dog model that's also more aggressive, but it's limited in its use. So we're trying to come up with a better, more representative mouse model, and we've teamed up with a very talented, again, speaking of collaboration, we've worked with a very talented geneticist here, Toshi Yakota, and has done a very seminal work looking at exon skipping in therapy for mice. So I'll show you some of that work. We're going with this mouse model. We have teamed up with him, and we're now studying these animals all the way out to 12 months of age. You need to do that because the phenotype at the earlier stage of the disease is very mild. In fact, you don't get a drop in ejection fraction earlier on. So there is no easy solution to this, right? You're in for a penny, you're in for a pound. So Andrew talked about this. So it's a long-term commitment. Don't expect quick solutions, right? So you gotta stay with the game. What we do see though is earlier on, we do see skeletal muscle changes, increased fat, and loss of skeletal muscle in this mouse model. When we do, so this is showing the loss of skeletal muscle and increased fat in these mice. When we wait long enough, up until 12 months, we do get a cardiomyopathy. So this is was just published with Toshi's group, and you can see the echo findings on the left and beautiful pressure volume loop showing early mild moderate cardiomyopathy when you wait up until 12 months of age. So very important finding, and we now have 2 MD PhD students working on this, looking at exon skipping in this mouse model. So we have some very newer technology with exon skipping that actually are now made it moving into clinical trial, and partly to the work we have done here in the mouse model. One of the important things, and this may be related to sarcoidosis, is inflammation. So inflammation is absolutely key for sarcoidosis, but also for Duchenne muscular dystrophy. On the left, the skeletal muscle, those are all fancy Western blots, but I can tell you that a few of the key markers of the inflammasomes, so the gastrin D, the ASC, and the interleukin-1 beta were all upregulated in the skeletal muscle. They were not upregulated in the heart. So corticosteroid is important to protect the skeletal muscle. It does not protect the heart. And now there is a new drug from Morelone that's been recently approved. It is a dissociative steroid agonist, very interesting drug, does not have the glucocorticoid, the side effects, metabolic bone side effects, and so on, but it does suppress the NF-kappa B and inflammation. So there is inflammation here in the skeletal muscle, and this can be targeted with traditional corticosteroids, but also with this new drug. So what's going on with the heart, and why is the heart so affected? So we turn to different molecules called tenascin C, and so this is quite a fascinating molecule. it is connected a lot to inflammation and fibrosis. It connects the matrix with the membrane. And as you can see here in the mouse model of tenascin C knockout, there is actually reduced fibrosis. So we asked the question is, how is this relevant in muscular dystrophy? And this is actually data from our cohorts, our patients. We have 450 patients now in a muscular dystrophy cohort. We have biomarkers in about 150 of those patients. Not the easiest group of patients to collect blood from a study. But in our cohort here, we were able to show elevated tenascin C levels. This correlated with reduced LV ejection fraction, correlated with LGE, documented fibrosis in these patients. So very exciting that we're able to make this finding. We need to, how do we prove that this molecule is important in myocardial fibrosis in this animal model? We went back and colleagues and studied that MDX mouse model I just showed you. We showed that the promoter is controlled and its expression of tenascin C increased with time. And as you age these animals, they have increased tenascin C expression. We see it in the plasma levels, those mice, and you can see the hearts there showing increasing dilation and fibrosis. The tenascin C is not a marker of fibrosis, but it's actually a pathogenic factor. In isolated hearts, when you infuse that molecule, it actually suppresses heart function, suppresses ATP, and impairs the ability of the heart to do work. It also triggers inflammation. So a very key molecule in driving the pathophysiology in this model. How do we prove it in an animal model? Well, we made a double knockout, tenascin C with the MDX double knockout, and these mice have almost no fibrosis in their hearts, so quite dramatic effect. We're able to show this now in human cardiac fibroblasts, that this tenascin C does upregulate fibrosis in these cells. They stimulate gene expression consistent with fibrosis. So very exciting, and we're now moving ahead. We're trying to target this in patients with muscular dystrophy. So very exciting, but equally exciting is this precision medicine therapy. So this is by far the best example of precision medicine right now. Exon skipping versus CRISPR-Cas genome editing. There is a big battle going on. Who is winning? Exon skipping so far. And as you know, there are 3 therapies that have been approved. Thanks to the work Toshi that have been doing, that are using the exon skipping, in which you skip the disease portion of the gene, you make a truncated dystrophin that's still functional, and it's able to provide benefit to the heart and to the skeletal muscle. The newer data is suggesting CRISPR-Cas can do this, but this has not been made into clinical trial. As you know, there's still limitations in using CRISPR-Cas in medical applications. So, but very, very exciting. This has also been recently shown to correct hypertrophic cardiomyopathy, and we're now looking at this at correcting laminopathies and BAC3 mutations. So the time is here. We now have genetic molecular therapies, exon skipping for Duchenne, but you very well may expect CRISPR-Cas down the road for Duchenne therapies, but also for other types of rare diseases. So I'll just stop there and thank my wonderful group of trainees that do all of this work, and just a wonderful group of collaborators nationally and international that we have been able to work with, including Ian and some of these rare diseases. So thank you.
He is Pfizer Canada's country lead for rare disease and gene therapy. Fred has over 25 years of combined international country leadership experience and joined Pfizer in 1999. He's been instrumental in bringing innovative therapies to over 50 markets. And these therapies have been disseminated very quickly. Prior to being in rare diseases, he held many other leadership roles within the country in sales and marketing, patient access, government affairs. So he carries, wide berth of experience, and which I think will lend itself well to his current role. I asked Fred to come today to talk about an industry perspective. Why would industry be, interested in helping develop novel therapies for rare diseases? and just sort of highlighting their journey about how they got into rare diseases and what sort of lessons they've learned along the way.
Let me just, here we go. This is my disclosure side. As Dr. Patterson indicated, I'm an employee at Pfizer and also a shareholder. So thank you and good morning, everyone. Once again, I wanted to thank Dr. Patterson and the committee for this opportunity today. I would like to specifically in discussing the course of Pfizer's interest in rare diseases, more bring in a context of public policy. And in listening to many of the presentations this morning, hopefully there's some information that I can share that shows how we can collaborate together and also what is actually occurring in the Canadian context that can allow healthcare providers, patient associations, and industry to bring rare disease medications, research, and clinical work to the forefront. Just getting into some facts and information I thought I would share is there are over 7,000 known rare diseases collectively, and if we look at the Canadian population and looking at prevalence, that would translate into about 3 million individuals, people with rare diseases. And some of these rare diseases in the field of cardiology that you are very, very well aware of, probably more so than myself, is ATTR-CM of amyloid, Kawasaki's disease. We heard also around Fabry's disease earlier, lambda-related dilated cardiomyopathy. This is just to name a few. And these diseases are often very difficult to diagnose. Even when a diagnosis is then made, it is also very, very difficult and very limited to get treatments to individuals. In many cases, only 5% of the actual diseases can actually be treated currently. As you just heard from some of the speakers, there's great work that's happening on the therapeutics as well as gene therapy front moving forward. Also, if we look at the diseases in general, we can see that 50% of rare diseases occur in children. We just heard a presentation about a horrible disease of Duchenne's muscular dystrophy, just to name one. They do have genetic predispositions and often lead to premature death. And as a result, this is why companies such as Pfizer want to get in and hopefully make a difference in the lives of these individuals. At the same time, when therapies do come to the Canadian market, unfortunately, the system, while getting the diagnosis and then waiting for treatments are positioned well, is just often sometimes the waiting to be able to get therapies can be quite long in the Canadian system. Actually, if you compare that to some European countries, 60% of the treatments that we have of the treatments in Europe and in the US, only about 60% of those come to Canada. And when they do, it's usually about 6 to 7 years before they can actually come into the Canadian marketplace. So as you can see, there's some work that we can be doing on the policy and payer front to have therapies come to Canada much more faster. And in doing so, organizations such as the Canadian Organization of Rare Diseases, CORD, has been very instrumental actually in leading the forefront and bringing together interested parties to be able to make that difference in the Canadian landscape. They've actually teed up about 5 different areas that they feel should be front and center when we're looking at rare disease research, treatment, and following patients to make sure that patient benefit in the end, which is what we're all working towards, comes to full fruition. And what they are indicating is improvement in detection and prevention, such as early childhood screening, equitable and timely evidence relating to these diseases, how the community can support, because even with a diagnosis, again, going back to Duchenne's muscular dystrophy, some of these patients are in wheelchairs requiring community support, providing access to promising therapies, and of course, how do we promote research? Now, what's interesting and why, I thought it would be interesting to be here today is to bring to the community's attention the federal government's prioritization of rare diseases in Canada. And they've actually, in kudos to, to the government, put $1 billion on the table to develop a framework, and then subsequently 500 million thereafter. So I do really want to applaud the government in doing that, because normally when these policies come, or discussion of policies, there's usually very limited resources put up front. It usually comes after. So I thought this was a different way of how they were approaching it. Also, they've had an opportunity to engage over 650 healthcare providers, patients, the pharmaceutical industry, and payers of how the system could be changed. And this is where Pfizer wants to get involved. To be able to help bring leading therapies, to the marketplace. And personally, when I've had the chance to meet with colleagues such as yourself, go across the country, the idea of the framework that is trying to be developed for rare diseases is not really well known. And I think this is an opportunity to bring it to the forefront. In particular, what is quite interesting, and you heard a number of presentations today about rare diseases, but Canada is currently the only G7 country that actually does not have a framework, or what the Europeans would call a national plan, nor a definition for rare diseases. So I think there's work that can be done there. And if we could actually even align on a definition and how that fits, as we see with our European and US colleagues, actually this would help underpin a really great start to the strategy. At the same time, if you look to Europe, they have adopted a definition that fewer than 1 in 2,000 people, that's sort of what they're using as a rule of thumb. Now, interestingly, if we look at Canada, Quebec has actually adopted that definition for their rare disease framework policy, which they're continuing to evolve. Now, Canada as a later adopter, there are, I think, benefits that we could look to Europe. We heard Dr. Edwards talk earlier about registries and what's happening in Italy, and I'll touch on that a little bit later. But these are the things that I think we could look to Europe, look to other jurisdictions. Not that we import them directly, but I think how we can customize and adapt them to the Canadian landscape and structure that we have. For example, Pfizer's position that we're putting forward and working with the industry association, there's 5 areas that we feel can help patients with rare disease and caregivers. And one is around how actually we put in place a patient care as the center of this policy, and what would go around that as a multidisciplinary support, how we can actually bring and embed best practices already happening in the Canadian landscape. Also, the review process of medications, can it be tailored? Because rare diseases, as you see, smaller in number, to be able to get to what you would need to in some clinical trials and what's required by the health technology assessment agencies are quite different. So tailoring these reviews, and that would lead to, of course, hopefully more timely medications coming to patients, and then real-world evidence that can be leveraged through registries, other ways of collecting real-world data. So that's sort of the vision that both the industry association, Pfizer, but also the patient associations have in rare diseases here in Canada. And I thought what would be also valuable to highlight in that, and sort of how are other countries or jurisdictions actually sort of making that work currently, that I would like for you to consider, because I think hearing some of the discussions today around funding, looking at how to improve the system, maybe this funding that the Canadian government is putting forward may be an opportunity for people online here today to be able to tap into if it fits the structure that the Canadian government is putting forward. But the 3 areas I wanted to highlight is, if we kind of look at best practices, is one is the establishment of centers of excellence, or in some cases you may hear them to be expertise, coordination of care through registries, and then accelerated pathways for medications. So if we kind of look to centers of excellence, I think an area I would like to highlight is France. France has a very unique structure when it comes to rare diseases. Actually, they were on the forefront back in 2005. They established what they call a national framework. They were the first before any other country in Europe, is my understanding. And they've actually did upgrades 2 additional times since then. And where they've kind of put their focus is actually partnering with the medical and patient community to ensure diagnosis, social care, how national policies and guidelines relate to diagnosis, how data is collected, and then the conducting of clinical trials. So all that has come together in their national plan, and then many European countries have taken that as an impetus to actually then bring into their own particular their countries. At the same time, they've also worked closely on rare oncology type of diseases, as well as rare physical disabilities that can occur. But if you kind of look at the centers of expertise, and I thought, in hearing with the cardiovascular community and the amyloid centers, maybe this is also something that may be close to heart, in that these centers of excellence are physical structures, meaning they exist within bricks and mortar, not put there specifically, but because they are there due to the delivery of care. And then they revolve around a single disease or group of rare diseases where they have a shared mission. And then there's a network that connects those throughout the French system. And actually, if you look across rare diseases, there's about 600 centers where they have coordinated care, research, clinical trials, as well as facilities for diagnosis. Then the second area where these centers are actually connected to registries, because what's important is to follow patients, gain additional data and research, work with industry, work with clinicians who want to do further research, whether it's in basic to all the way to different phase 3 type of studies. They actually, that's how they want to facilitate. And the registries have become very important in Europe. If we look to Italy, and again, I'd refer to Dr. Edwards presented a discussion in her presentation of using the Italian registry data. So as we know, it's not perfect, but I think it's an illustration where what they've done is they've looked at both a national registry level for rare diseases. They look at the regional level, which probably could be similar to our provinces, and very disease specific. They've made it a decree within their legislation to create these national rare disease registries, and also it's based upon the National Institute of Health. So the healthcare is very decentralized, again, fairly similar to Canada, in that it happens at the regions, as well as in some cases even at the hospital level, of how they facilitate care. So I thought, when we look at registries and where Pfizer and my other colleagues within the pharmaceutical industry can partner and support, I think this was a structure that's of interest to bring to the medical community here in Canada. And finally, I wanted to talk about access to care when it comes to rare diseases, or what you will also hear sometimes as orphan medications. So if we kind of look at that area, there are certain flexible pathways that allow patients to get faster access to medications than what you would see in some other jurisdictions. And I thought it would be interesting because there's 3 different buckets that one can look at when we're looking at facilitating of faster access. So there's the German model, which actually bases upon if a pharmaceutical company wants to bring a medication to market, they look at a threshold of what that revenue would be, and depending on the threshold, they allow for a more facilitated, faster access. If it's a little bit beyond that, then there is a more rigorous AMNOG process that they would have to go through. Now that is not specifically just for rare diseases. It's actually across many other medications, but within rare diseases themselves, what they do try and do is actually look at how they would link the rare disease medication that's being assessed around its regulatory approval, looking at real world data collection, and then also reimbursement policies. So they've tried to integrate that within their system. Then if you look at France, what France does, which is also quite interesting, they look at if you have a rare disease or a debilitating disease based upon the definition that they put forward, they allow what they call an ATU process, which is looking at authorizing temporary utilization. And this comes actually before the medication is actually approved by the regulator. And they have two parts. One is a named patient, which is somewhat similar to the SAP process in Canada. But then they have another one, which is very interesting, is more cohort, which would be a broader group of patients. And what that allows is for patients to get faster access if they meet that definition, allows for data collection. It also allows for price negotiations after the fact, and it allows for real world data to be collected that can also be sometimes used in the submission process itself. And then finally, if you kind of look at the UK, they have another system which looks at, again, as a health technology assessment country, looking at the threshold for a QALY. And normally the QALY that's utilized in quality of life year gained is normally about £30,000 per QALY year. For rare diseases, and depending on the definition that they're utilizing, which is more severe, they actually bump that QALY up to about 300,000, between 100 to 300,000 per QALY. So again, as you can see, there's different elements that different countries have adopted, even though they're within the EU, within their country, to be able to help facilitate, better access to care and tracking of care. And again, this is something that is very interesting from Pfizer around public policy to bring to the discussion. The other area when it comes to research and development of medications, Pfizer has also been leading in a number of different areas over the past couple of decades, where we've looked at and been involved in rare hematology, neuroscience, inherited metabolic disorders, cardiovascular, and nephrology. So we've, as an organization, have been committed to leveraging this expertise to bring new innovations to Canada and to patients. And as part of Pfizer's ongoing process in focusing on these areas of science, we want to ensure that we can be the best to deliver that, to patients within the healthcare system. But we do feel currently the healthcare system within Canada and what we're hearing from patients can actually have some improvements. And at the same time, we want to encourage in how we select therapies to look at not only internally, but also external innovations on rare conditions within the core categories that we're looking at. Finally, I want to take this opportunity to touch upon, how our corporate commitment to collaborate and partner with the healthcare community and with patients. Actually, I suppose today, not being a clinician myself, more of a policy individual, of being invited to have and share these thoughts with you is an illustration of how we can partner with experts such as yourselves. If we kind of look at more how we've looked more around partnerships, we have supported patient associations and healthcare providers, just to name a few, fellowships, for example, with clinical organizations such as the Canadian Cardiovascular Society, the Canadian Pediatric of Endocrinology, through our medical group, independent research grants and funding. We've also had the ability to partner with clinicians and patient associations in the Canadian Hematology Society and sickle cell. There's work that we like to partner with when it comes to healthcare systems and quality improvements. Also, there's work that clinicians would like to do that's not always necessarily connected to the core areas of Pfizer. So there's unrestricted grants that can help generate evidence that's available, partnerships with institutions. So here's just a little bit of a flavor of where over the years and currently that we're actually supporting. So in summary, I just wanted to thank each and every one of you for listening today and knowing how Pfizer wants to partner with rare diseases and in the Canadian policy work. We do feel that, you know, compassion, access, fairness, and equity, which are core principles of the Canadian Healthcare Act, are near and dear to what we want to support, as well as creating a holistic healthcare system that puts the patient at the center and policy to ensure that patients get diagnoses, get earlier screening, and get treatments as quickly as possible. And I think someone indicated earlier on February the 28th, actually it's normally February the 29th, but it only happens every 4 years. So February the 28th is Rare Disease Day. I do invite you to participate, and I thank you for the opportunity to be a part of this exciting program today. Back to you, Dr. Patterson.
Thank you, Fred. That was excellent. Really appreciate you coming on and giving your perspective and the perspective of industry, and look forward to the discussion after our next speaker. So our next speaker is Dr. Chris McMaster, who's the Scientific Director of the Institute of Genetics for Canadian Institutes of Health Research and a Professor of Pharmacology in the Faculty of Medicine at Dalhousie University in Halifax. He previously was the Carnegie Rockefeller Professor and Head of Pharmacology at Dalhousie University, and he was also the Assistant Dean for Graduate and Postgraduate Studies in the Faculty of Medicine at Dalhousie University. And he also mentioned earlier he has his own research interests, and they do overlap with today's topics. He has looked at genomics to study causal genes for human genetic diseases. And one of the diseases he's looked into, according to his bio, is a muscular dystrophy. So a little bit of overlap there. And then finally, Fred just mentioned that there's $1.5 billion on the table. So I'm looking forward to hearing about that in this next talk. Thank you, Chris, for coming.
Thank you very much, Ian, for the invitation, and to the organizing committee for thinking of me, and to Bonnie for doing the real organizing. And it's a pleasure to be at the Rare Cardiac Conditions Conference being hosted by Ottawa Heart. As mentioned, I've got 2 jobs, half of my life, which I've had for just over 4 years now, as being the scientific director for CIHR's Institute of Genetics. I've just been renewed for 4 more years. And after that, as a scientific director, they're done with you. And the second half of my life is professor of pharmacology, which I have been for 25 years now at Dalhousie University. Disclosures: according to the form I was sent, because I am the scientific director of CIHR, I do have a relationship with a not-for-profit, and attendees of this conference may be funded by this not-for-profit. And I also sit on several committees at CIHR that can influence research and programs. And as a professor of pharmacology, I do have a university spin-out that's been in existence about 10 years, and I'm a co-founder and shareholder, but there is no cardiac research conducted by this spin-out. I'd like to begin by acknowledging that we, Dalhousie University, and the CIHR Institute of Genetics are both located in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the treaties of peace and friendship with the Mi'kmaq and Passamaquoddy peoples, first signed by the British Crown in 1726. We're all treaty people. So for those folks who don't think about CIHR all the time, and I don't blame you if you don't, this is sort of where CIHR sits in the landscape of the larger Canadian research enterprise. There's a lot of places that research takes place in Canada, but those places that, of course, most folks that are attending here can access funds are what are called the tri-councils, which is CIHR, NSERC, and SSHRC, which tend to fund operating, and Canadian Foundation for Innovation, which funds equipment and infrastructure. CIHR is the only research funding organization that's under the Ministry of Health. And as you can see, there's a governing council for CIHR that the president reports to, and Science Council is advisory to the president. And then there's the senior leadership team that actually enacts these folks enact exactly what CIHR will be doing for its living. Every other funding agency that you saw that you could potentially apply to is actually under the Ministry of Industry, Science and Economic Development, which is important because both industry and economic development are part of their mandates, whereas CIHR is health, that is the mandate. There are 13 institutes at CIHR, of which Institute of Genetics is one. There are many that would be germane to folks looking at this conference, from gender and health to circulatory and respiratory to aging to population to nutrition, metabolism, etc. All of the strategic, or essentially 99% of the strategic funding that comes out of CIHR comes from the institutes, whereas and I'll show you on this slide here, most of CIHR, we've got a bit of overlap here. See if it can be fixed. Nope, but anyways, apologies. I don't know why it's doing this. But as far as CIHR goes, there's directed non-discretionary funding that flows through CIHR, but CIHR cannot move that funding around, and they tend to be the Canada Research Chairs and the Vanier Banting Awards, as well as Government of Canada priorities, which are currently HIV/AIDS, AMR, and the SPORE networks. And then, as you can see, in terms of discretionary funding, where CIHR can choose where to spend the money, 83% of CIHR's discretionary funding goes to the project grants, which are essentially the wild, wild west, where anybody can propose anything. And if your peers, I have heard people do this, and I used to do this myself, CIHR won't fund this. CIHR makes no decisions on who or what will get funded. It's, if you look to your virtual left and right, those are the folks, because they sit on the committees, that choose who will get funded. And 83% of CIHR's discretionary funding goes into project grants. Here's where the institutes sit. So this is the funding that can be essentially used for programs that are not project. So essentially strategic funding. And this sliver is the training and career support, which are studentships and fellowships. All righty. So as far as the Institute of Genetics goes, our vision is to maximize equitable health outcomes for all, driven by world-class interdisciplinary research in genetics. And we have 4 strategic commitments. And for those who want to read our strategic plan, these are in there and these are what they are. Easiest place to find it is just Google CIHR IG strategic plan. But there's 4 commitments. One is facilitating genomic medicine. The second is improving genetic disease diagnosis and therapies. The third is embracing diversity, inclusion, and Indigenous rights. And the fourth is strengthening the community, essentially with respect to genetics, genomics, and its understanding. So what do we mean by these things? Well, facilitating genomic medicine, we want to move towards predictive, personalized medicine, where we're looking at genomic medicine as a tool, using health data as a tool, and use these 2 things to better predict monogenic and polygenic diseases. We want to try and prevent adverse events by incorporating pharmacogenomics into the clinic as best we can. Of course, report on infectious diseases. COVID was a great example of that from the viral side and from the human health side. And ensure that as far as genomic data shares goes, we've got the best ethical and policy standards in place and the computational technologies to be able to do so. So basically, we'd start with patient needs, research driven by the patient needs, developing both therapies and better diagnostics that can be brought back into the clinic, and see if these work for the patients, and embedded in both of those are the best in healthcare ethics and research ethics. By improving genetic disease diagnosis and therapies, we're thinking about ICD, as I've mentioned before, ICD-11, or embedding ORFA codes into ICD-10, which will probably be what happens. What ORFA codes are they're the coding for all rare diseases. So in ICD-10, there's about 200 checkboxes for rare diseases. Right now, there's 7,000 rare diseases. ORFA codes has the other 6,800. So if you have ORFA codes in place, you've got lots of things that you can then do. You can more accurately track inherited diseases in Canada's population. You can get more accurate and prospective data on mortality, morbidity, cost for diagnosis and treatment, and simultaneously determine what are the direct costs to the hospitals themselves and the healthcare system at large, which we currently cannot do. Indeed, Canada has zero idea how much they actually spend on diagnosing and treating rare diseases. So then how do you determine the appropriate level of investment in diagnosis, care, and research? If you look at retrospective studies, though, they show that rare and inherited diseases as a class result in the highest level of mortality amongst kids, the highest pediatric hospital bed occupancy, about 1 in 3 beds, and the highest direct cost to the pediatric healthcare system. If you implement ORFA codes, you could actually get all this data prospectively moving forwards. And I think that would be a huge aid to the system, because if you walk up to your Minister of Health or Minister of Finance and say, you know what, by far the biggest reason kids die in Canada, the biggest reason they end up in hospitals, and the biggest reason you're spending money on kids' health and disease is rare inherited diseases. And I dislike the term rare so much. I prefer to go with the genetic or inherited, is because of this disease class. I think you'll start to get some attention, but until you can provide that information, it's really hard to get traction. We're also looking at accessible and affordable gene therapies. Oh, we're also, pardon me, using genomics to affect the diagnostic odyssey. As was pointed out by Jody, it takes about 7 years for your average rare disease patient, often child, to be diagnosed. It costs about $25K. They've got about 2 or 3 misdiagnoses. And we're at the point now where a genome costs about $1,000. And the nice thing about a genome is it doesn't change. So you don't have to keep going back and running the same test over and over again. You can just reanalyze the genome based on what we know a year later or 2 years later or 3 years later in terms of new genes that could be causing a disease. So it's a much more effective way to potentially do it, and hit rates, if you do it really, really well, that people are reporting around the 40–50% range, which is for a diagnostic, for a single diagnostic test, is actually very, very good. We're also looking at trying to access affordable therapies. Canada has its biomanufacturing mandate right now through the NRC, and the NRC has actually gotten and ramped up its capacity to make AAV vectors for both preclinical and recently clinical work. What we would like to do there is actually move a platform working that could take a whole of government approach that could be side by side with industry, where we could work with Health Canada and their new innovative clinical trials legislation to try and find a great path forward for rare diseases that's predictable as far as HTA approval. But we would also like to work with the NRC and their gene manufacturing capacity to actually use academia as a second process beside industry. There's 7,000 inherited diseases. Industry is currently super keen on about 200 to 300. There's another 6,700 out there that we could tackle, that would essentially be taking a whole of government approach. If we do this, you significantly de-risk things. Professors are already being paid. Physicians are already being paid. We already have the labs and the infrastructures and the hospitals set up. The government just needs to come up with the cash to actually move things from point A all the way to the end of the process, which is essentially the preclinical work and the clinical trials themselves. And right now, it's the preclinical space that we currently do not fund very well in Canada, and we're hoping to try and fill that gap by moving vectors from essentially mouse to man, so that you actually have the evidence in hand, working with the NRC to do so, to actually then start a first-in-human clinical trial. And finally, we need a national rare disease clinical trials and treatment network in Canada. As was pointed out earlier, Canada's rare diseases patients often don't get access to medicines when they're first available. It's often many years later when they're improved in other places. The income from clinical trials, as well as the access to therapy for free during the clinical trial period, is not available to Canadian patients. Rare disease therapy approval is often taking place in the countries that run the clinical trials, because you've been working with the HTA throughout the clinical trial. But since we don't have a national rare disease clinical trials and treatment network, and I've also got treatment in there, which also speaks to actually trying to get either virtual or real treatment networks or centers of excellence, whatever you want to call it, in place. So these are things that we've heard that are actually in our strat plan that we think need to be acted on as well. And then this is actually directly from our Institute of Genetics strat plan, which I'm sure you've all read and memorized, from JAMA Cardiology in 2021, where they were looking at sudden cardiac death in a cohort of patients. They found about 1 in 5 patients who died from unexplained sudden cardiac death had a gene that was essentially a single gene disorder that had a known variant that was either known to be pathogenic or highly suspicious to be pathogenic. 1 in 5 of healthy adults that died of unexplained sudden cardiac death. So that's not rare. That's actually quite common, I would think. And this is something for sure that if we actually could incorporate genomics better into the healthcare system, hopefully something we could do something about. We're also looking to embrace diversity, inclusion, and Indigenous rights. Genome databases right now are not representative of the population at all. When you look at the large genome databases in Canada, we have no clue because we don't have a pan-Canadian human genome library. For those of you who pay attention to ResearchNet, there's currently a call that is closed to put together a pan-Canadian human genome library that can ensure Canadian genome databases are now equitable when it comes to EDI and Indigenous peoples, because if you want to transition from genomes that are used in the research space to the clinical space, you need to make sure it works for all populations. If we actually do diagnose people earlier and have ICD coding in place, we can actually recruit people into the clinical trials, which the National Clinical Trials Network, as new medicines become available either from the public or private sector. But when we have a lack of knowledge of underrepresented populations, it brings challenges to this in terms of trying to figure out which variants are actually causal for those folks to get them recruited. And indeed, if we have a large pan-Canadian human genome library, we can start to think about more accurate predictions for polygenic risk scores for more common diseases, including different types of heart disease. And one of the nice things about this is if we actually do it really, really well, we can make this part of a patient's healthcare record such that their genome will actually become part of a healthcare record, and its analysis and the routine pinging of the genome on an annual or biannual or every 2-year basis to constantly update so that at least the clinician can be informed in terms of what is considered material within Canada as actionable items, or at least items you can keep an eye on as far as your patient goes, moving as they move down their lifespan. We also want to strengthen the environment. The clinical workforce needs to have a basic understanding of what genomics can do for them and how it can help. They don't need to understand genomics. They just have to know when's a good time to order the test. And we need to get a process in place for that to actually take place. As I said earlier, is clearly better at this point in time. We need to develop interfaces to enable decision-making for the healthcare professionals when to implement genomics. And we need to start to scale medical and clinical genetics and genetic counseling. It's predicted right now there's about just over 1 million genomes sequenced worldwide. It's expected to be 60 million genomes sequenced worldwide in 3 years. And you can imagine the power that's going to come with that. But if we start to do some of the things that I've talked about earlier, the amount of genomes and the amount of genetic information that will then be part of a patient's care record, if we use the current way they're counseled genetically, it can't be scaled. So we need to find a way to actually take care of this and sooner rather than later. Of course, we all know computational biology and bioinformatics and its interaction with health data is the major bottleneck in everything we do right now on the genetics and genomics and other omics fronts. And so we need to increase capacity in computational biology, bioinformatics, and in interaction with health data using AI and machine learning to do so. And the library might be a good place to start. We need to make sure that our workforce, there's EDI within our workforce and within who we study. Encourage and reward fair principles by researchers. Sharing is caring. Don't keep it all to yourself. And we also want to make sure that there's increased public awareness of what is realistic in terms of what genomics and personalized medicine can actually do for the patients so they can then make informed decisions. We also just recently published in CMAJ what are core elements of a research genomic consent. So it's a guidance for Canada. And really it talks about the main themes in here. It's for research. So it's reconsent if they're not already consented, to enable international collaboration, use of future research, their use for future research, controlled access, data stored on Canadian servers, the duration of the storage, opt out anytime, re-identification if something material is actually seen and is deemed to be material for recontact. It's there, it's very handy for a lot of researchers if you are submitting your REB for a research proposal to point to this, because it does essentially act as a guidance for Canada. The Canadian Association for REBs is presented there twice to great aplomb, and they're very grateful that they now have a document to work from so that REBs can be consistent in what they're looking for. And this is just the core elements within the consent. You can add all the bells and whistles necessary for your particular jurisdiction. And finally, looking forward, aspirations for genomics in 10 years, every inherited disease gene and potentially every variant will be known. Genomic literacy will prevail amongst clinicians and the general public so they can make more informed decisions concerning personalized health. We suspect over 100 million, and this is probably an underestimate, human genomes will have been sequenced, adding unprecedented accuracy to prognostic health and disease predictors at an individual level. Public, patient, and policy maker shared values will be incorporated into genomic medicine delivery. The Canadian Human Genome Library, which is in the process of being launched as we speak, will enable machine learning and AI to determine much more accurately what keeps people healthy and makes them sick. We highly suspect within a decade, probably most babies born will have their genome sequenced at birth, and your genome, for those who require it, who are alive at the moment, will be part of your healthcare record and probably accessible on your smartphone or laptop to better enable personalized patient-informed care. Pharmacogenomics will be standard procedure, determining specific drug dosing and preventing undesirable drug-drug interactions at an individual level. Therapies for treatment of inherited rare diseases will be increasingly accessible and affordable, and will start to combine other omics technologies with genomics to improve disease diagnosis and health outcomes, and genomics will be a primary vehicle for health equity. I kind of screamed through those quite quickly because I wanted to leave lots of times for questions, and I hope that is a interesting overview for you folks, and thank you very much. And if you want to know everything about the Institute of Genetics, including when we launch funding opportunities, you can sign up for our Twitter, or you can contact our knowledge mobilization and communications person, and she will actually sign you up for our quarterly newsletter that also talks about all of our funding opportunities and all sorts of other fun international and national advances in genetics and genomics.
Thank you very much, Chris. That was a great overview. So I invite the panel members back, and we have about, let's see here, 22 minutes, I think, for questions. So if anyone has any questions, please either raise your hand or type them in the chat. I guess I'll start with a question. You know, we've heard, and you know, from a number of people, both in the first session as well as this current session, about the need to develop a network. You know, whether it be more networks for specific rare diseases, but then potentially also a network of networks that helps all of these rare disease programs. And then, Chris, you mentioned about potentially having a network to help launch clinical trials as well. So, you know, do you see, Chris, CIHR having a call at some point to the research community to ask for submissions to develop these types of networks? You know, we've had similar calls in the past for other things like developing image networks or, you know, but would there be a call in your mind where, you know, there would be a call to help develop an overarching network for rare diseases and potentially invite industry partners like, you know, Pfizer or other companies that would be interested?
Yeah, thanks, Ian. So I have to be careful because I'm not allowed to talk about funding calls that could be happening, because that puts everybody who's listening at a conflict of interest. But what I can say is that these are things I've talked about openly in the public at other venues, and through our consultations with our Institute Advisory Board, with CORD, with Health Canada, with international partners, and with industry, is that what I've spoken to are the priority areas that have bubbled to the top that are at least most germane to this audience, that CIHR feels are worth moving forward with. And you can take that as you may. But these are things, everything I talked about are what we would desire to see implemented one way or another to advance the health of Canadians with inherited diseases. I will say the clinical trials and treatment, so the trials part is pretty clear, and the treatment speaks to sort of the centers of excellence idea, whether that's a virtual or real bricks and mortar centers of excellence, we'd leave up to the experts to determine. But we think the two need to be tied together, because of course you need the patient sorted out for the treatment to sort of be aligned. do the clinical trials. And I would think it would be a motherhood for all, similar to pediatric cancer. You know, one of the things that, and you guys have brought about it at all, it seems like the heart people are farther along than many other inherited diseases, where if somebody shows up with an inherited disease, if you show up with pediatric cancer, well, cancer kills, for every inherited disease kid that dies, there's only, it takes, well, the other way around, for every pediatric cancer kid who dies, which is sad, you've got about 5 or 6 times the death rate for inherited disease kids. And if you look at pediatric hospitals, they occupy 1 in 3 beds inherited disease kids when people look back retrospectively. So it's a huge burden, but they're not counted, which is why we need the ICD coding to take place so we can start to count them. And the ICD coding can then be patient registries at the same time if you actually pay attention and do it well. So, and that could then, if you've got good patient registries and it's backed up by genomics, feed into actually clinical trials and treatment. But there's a clinical path as well, and there's supports in place for kids with cancer. There's supports in place for the families of kids in cancer, because when you walk in the door, there's a pediatric cancer door. There is not an inherited disease kids door or adults door, which I think we need to, hopefully these will start to be the seeding of a similar type of thought process. And as we start to get towards more precise diagnosis using genomics. And like I said, the nice thing about genomes, and we don't do this routinely in the clinic, is we get somebody's genome done, we take a look and we say, oh, there's no known gene, and 50% of patients can be diagnosed. It's rare that we go back and say in a year from now, we're going to reping that same genome to see if something new has come up, or 2 years or 3 years and 4 years down the road to try and diagnose that patient. And I also think that it's something we need to actually start implementing a sort of routine process when it comes to the clinic. I don't know if I got to the end of your question, but if I haven't, please ask some more.
Yeah, that's, I think you have. Maybe before Gavin, Fred, do you have anything to add to what was said there? No? No, okay. Gavin?
Yeah, great. Thanks, Ian. Thanks, Fred and Chris for that those wonderful presentations. So, you know, it's great to see rare diseases at the forefront of a national strategy, funding strategy, and care strategy. So I think it's great to see that engagement. You know, I think we all need to remind ourselves with cascade screening, family screening, we identified 3 to 5 more additional family members when we're dealing with genetic disorders. So the name rare is in a way a bit of a misnomer, right? Because once you dig into this, you start finding a lot more affected family members, and you know, as the name implied, it cascades into a lot more patients being affected. So I think it's great that we're taking this so seriously. I think there is also the legal issues. I think we need to also address and talk about, and that's the Genomic Discrimination Act, in which patients are no longer, insurance coverages are no longer denied to patients with genetic disorders. I think that's it has been challenged in the federal court by 1 or 2 individual groups, but was upheld. So it's great to have that legal framework so patients with genetic disorders can be protected. In the US also have this, it's a bit stricter in the US, so there's absolute protection. But it is here in Canada, and it is available to protect patients and their families. So I think this has also facilitated the increased uptake and of genetic testing now that patients and families can be protected. Thanks.
I don't see any other questions at the moment. Gavin, can you speak a little bit to, it sounds like the networks that you've had to create for your translational experiments have mostly been international collaborations
Right.
rather than within Canada. So does that speak to, you know, the more limited number of individuals like yourself at a local level doing this type of work?
Yeah, so I mean, so just going back in time with my work, so I think yeah, no, absolutely, I think it's important to reach out nationally, but definitely international, right? Because there are experts out there doing some amazing things, And you know, so is Canada. So I think having everybody on board is always the best strategy. You know, it's a balancing act, right? How far are you going to reach out to people internationally versus nationally? So the Fabry's cohort, for example, is it's a national, right? We're part of the Fabry's disease guidelines, the CFDI. That's headed by Mike West in Halifax, because it's a large cohort and historically he has led that. So we do have a national team. As you know, we have done a lot of work here in Alberta with Fabry's disease, and we're connected nationally with the Fabry's centers. The muscular dystrophy, lots of work here in Edmonton, and now Calgary's on board, and I think your colleagues in Ottawa now will be on board. Our colleagues in Montreal are on board, and colleagues in Toronto are on board. So we already have a lot of the major centers with muscular dystrophy, and our aim is to create the largest cohort of patients with muscular dystrophy, with a focus on their cardiac respiratory care. So I think, you know, you start off locally, but you build very quickly nationally. And both the muscular dystrophy and the Fabry's studies have received funding from funding organization, but also from industry. I mean, Sanofi and Takeda and other companies have funded some of our work, and has led to a very fruitful academic industry collaboration and progress. The explanted heart has been also, we're now working with the Toronto group, Phyllis Billiot and Tony Gramoloni and Slava Ipelman to look closer at some of the rare cardiomyopathies and their changes that are going on there, as in addition to our international collaboration. We're also working with Seema Mittal from SickKids as part of the National Heart Failure Alliance. So we're looking at some of the diastolic restrictive cardiomyopathies. You know, that's a really interesting cardiomyopathy, often titin mutations that are driving those. You know, that's be upfront for genome editing, for example, because those patients are so sick, either they die or they make it to heart transplant at a very early age. So bottom line is, Ian, you start locally and you build nationally, and then you go, then of course, you build internationally.
Okay, there's a comment here in the chat from Julie Richer talking about the bill protecting individuals in Canada, saying that DNA, RNA, and chromosome results are protected, but the bill does not protect the results of any cardiac testing that results from knowing this genotype.
Right.
Okay.
Right. So companies can still figure out that you have heart disease, but they can't access your genetic data. So. Yeah.
Mm-hmm. Maybe another question from me. So both Fred and Chris, I know you both have a lot of international ties. Fred talked about the Centers of Excellence in France, and Chris, by email, we discussed an initiative that CIHR was involved with, to a call for funding, an international call. So, you know, can you briefly discuss, both of you, how we can leverage these opportunities internationally? So in terms of either for centers or individual researchers, is that something that we were likely to see more of going forward? Is there going to be more international collaboration to help perhaps countries like Canada, which are perhaps behind some of the other G20 countries in developing these networks? Can we have opportunities to work with these other G20 countries who have these networks in place?
I can start for a second, Ian, if you'd like. I would certainly encourage people to reach out to these countries, because it looks like Canada now wants to move towards a national clinical trials and treatment network. They want to start implementing ORFA codes. They want to start moving genomes to the beginning of the diagnostic process versus near the end of the diagnostic process. And a lot of these countries have already sort of been there and done that. So it's sort of implementation research, and I'm sure they will know what worked and, more importantly, what didn't work for them, so that we can avoid mistakes and hopefully focus on wins, and then hopefully add on, because Canadians are very smart, to make it even better than what exists elsewhere. So that when we're looking to diagnose patients and when treatments come down the pipeline, if we're looking to bring homegrown treatments into the clinic, we need to do so. And the other aspect is for a lot of the rare diseases, they're rare. So you do need to, if you're looking at both diagnosis and treatment, you need to work with international folks. As far as funding goes, it's sounds easy on paper, but I will say prior to taking on my role at CIHR 4 years ago, I didn't realize how difficult it is to get memorandums of understanding between countries existing. Probably the best one we have is with the European Union right now with CIHR when it comes to inherited diseases. But I will say the other thing that I get to do as part of this job is I do get to sit on a lot of committees. Both people had mentioned IRDIRC, which is the International Rare Disease Research Consortium, and David talked about the paper IRDIRC published on clinical trials recommendations for rare diseases, and Jody spoke to their work as well. And I'm on the executive of IRDIRC, so I actually do get to then have a say in what are sort of the priorities internationally for rare diseases. I sit on others for the European Union and in the States and Australia, et cetera, and starting more so in Africa. So we are you do get to influence sort of policies and where funders and policymakers are thinking at the same time with my particular job. And I'm not sure what your networks look like, but I would encourage you. But as Gavin pointed out, Canada has to start locally and then build nationally and then collaborate internationally. And we're trying to facilitate the national piece at CIHR moving forward. And then once we have our national piece sorted, it'll make it a lot easier if there's a point of contact within Canada, like a clinical trials and treatment network, to then work internationally. That's sort of my thinking anyways.
Yeah, just building on that, Dr. Patterson, I think, you know, the experience that we've seen and sort of what I was mentioning, if you kind of look to Europe in particular, they've started this journey of trying to not only within country, but also across the European Union to sort of share data and go through the different hurdles around data sharing, around guidelines and laws of data privacy and what have you. So a lot of that work has occurred and they've evolved. As I mentioned, France, which started with their national frameworks a number of decades ago. So what they've been able to do is along the way get some key learnings. And I suppose the question would be is how can we connect? And maybe this is where industry as well as academia can help reaching out to kind of make those networks to see how, instead of repeating the same steps, sort of get to a next level that these countries have already learned, so that instead of going along the same journey, hopefully you can kind of skip a couple of steps and get to get to another area. The other thing is, Canada, because even though we have a healthcare act, the Canadian Healthcare Act, healthcare is delivered provincially. So, and also there's the public, private, and out-of-pocket type of systems. So, looking at how these frameworks in Europe can be, because of the fragmentation there, can also help support how the Canadian system, given that provincial and territorial network, there's some lessons learned as well. Now, that being said, I think if I look to work, for example, in the amyloid area, if I look to rheumatology work, if you look to how registries have been evolved, there's really great work that the Canadian clinicians are actually doing and actually reaching out pan-Canadian wise. I think the problem is just time and resources. So this is where we're hoping that potentially with the government coming forward and recognizing in rare diseases, orphan drug, that if they could put investment on the table, different areas of priority and individuals can step forward, hopefully tapping in to start making these networks come to fruition. So that's sort of my thinking. We're still in the infancy work, but I think there's definitely best practices globally that can be tapped into very, very quickly.
Yes, Chris, yeah.
Oh, just one quick thing. It's just one of my pet peeves that I think for somebody who's been in the inherited disease community for a while now is that I prefer folks to I hate the term rare, so I never use it. and I try and use genetic or inherited because that's about 80% of rare diseases anyways, because when you say rare, people think it's rare. But as an umbrella, inherited diseases, as we know, is the huge problem. And that I wish we thought about inherited diseases the same way we thought about cancer. Those are really the two diseases of DNA. When people think about cancer, okay, cancer, will affect 1 in 9 people in Canada will probably get some sort of cancer. And we know cancer is thousands of diseases. When you get down to the DNA level and you get down even within a single tumor, you've got different cells with different types of DNA variants. And inherited diseases, they're monogenic diseases, they're single gene disorders, and they're huge. And if we thought of it as inherited diseases, cancer, and took that sort of umbrella type of an idea and then said, cancer is then broken down even in your ICD coding. You've got cancer, and then you've got what kind of cancer and what subtype of cancer and subtype of cancer you're working with. If we thought of inherited diseases as a class, I think we do all of ourselves a favor of saying inherited diseases, and we saw the numbers that some people put in their introductory slides, which is a start. I would get rid of the term rare as often as possible because people tune out. As soon as you say rare, they think it's rare, when it's the most common thing that kills kids in Canada. So I really wish we'd, even though it's in this, and Canada's rare disease strategy is called the Rare Disease Strategy. It's the Canadian Organization for Rare Diseases because it's been the term used for forever. I wish we'd drop it and move on. Because when you talk to the general public and policymakers, it doesn't resonate. As soon as they hear rare, they stop listening, which is a shame, but true. So the other part, I guess, was people talked about Health Canada's $1 billion. And I can give you a little bit of, and this is publicly available information, half of that $1 billion is going to go into the public sector, and half the $1 billion won't. And the $1 billion that'll go into $500 million that'll go into the public sector. In terms of all of the consultations that I went to that Health Canada held publicly, the Canadian Organization of Rare Diseases and others held publicly, there's two big concerns. One is some rare disease drugs are very expensive. Not all treatments and not all drugs are very expensive, but some are. And of course, there's disparate access across the country, depending on the province you're living in terms of can you get access to this rare disease drug or gene therapy or what have you. When the cost is very high, depending on the province you're in, you may or may not get it, which is very sad for the patients and also leads to very headlines that governments don't want to see, provincial and federal governments don't want to see. So I imagine they want to do, they're thinking of more of a sort of a mini quasi-national pharmacare for inherited or rare disease drugs as part of this strategy, and considering price points for some of them, that could take up large swaths. But I also know they're thinking about solutions for rare disease patients that can, and some of these we've talked about today, that I hope they bring to the fore. I still don't know what's going to come of this, but from the consultations, it sounded like it was toing and froing between those two types of things that people were trying to assess.
Excellent. We have time maybe for one more question before we head to our break. There's a question from Elizabeth Swigum out west.
Hi, thanks. So Elizabeth Swigum, I'm a cardiologist in Victoria, BC, and a heart failure cardiologist. I also at Cardiac Services BC, and that chair to try to improve access and equity for heart failure management in the province of British Columbia. And we certainly I think are lacking in data. And when we're going back to the networking opportunities, I think this is an important relationship building opportunity. But when we're looking at smaller centers, for example, our center, there's a lot of disparate access and equity to the expertise. But once the expertise is also, the champions are there, then there's the infrastructure inequity. And so my question is this, and it may be, coming to all of you, but my question is, are there some mentorship opportunities where you've already established, I know Andrew Cron mentioned this earlier, you've already established a momentum? And then how do we mentorship the smaller sites to engage people like myself, where the infrastructure to support the actual data acquisition doesn't currently exist? And I've had, conversations with David Birney before about cardiac sarcoid. We have a genetic medical genetics embedded in our clinic. So there's all of these opportunities for all the smaller sites throughout Canada, but there might not be the infrastructure support to implement. And coming back to the implementation science and how to do that. So is there a way to mentor these smaller programs and perhaps support them with the infrastructure through the work that you've already done and through the funding that you've already acquired?
I mean, I can speak. I'm not so I guess it would depend on the disease that we're talking about. Some networks are further established than others. One, we heard about the sarcoid network earlier, which you mentioned. We know about the inherited arrhythmia network. There is a growing network for amyloidosis that we'll hear about in the amyloidosis session this afternoon. But you're right, there's there are a couple of issues which you've raised eloquently. You can have access to experts within these networks, but that may not solve the issue of having access to resources needed to provide care. So I work in MRI, and not every center has a cardiac MRI available, which is used to help with the diagnoses for some of these conditions. So I don't know, the short answer to it. It requires some thinking about how resources are allocated. In the short term, it means I'm sure that some patients are having to travel to get the testing they need. In fact, when I learned,
it wasn't even just the diagnosis. It's to help contribute, because patients really are interested in contributing to this research. So it's for the patients to contribute to this research and to the registry. And that's really the infrastructure I'm talking about. I'm not necessarily talking about the diagnostic inequities which you've identified, but even just the ethics approvals and all of the just the infrastructure to be involved in networks and in registries. And how do we kind of grow our group that way?
If I can jump in there, Elizabeth and Ian. So there is also the Hero HCM, right? That's also Rafik Tadros leading from Montreal, that's now capturing national hypertrophic cardiomyopathy. So a great strategy, another group we haven't even talked about, project across Canada, the Tomorrow Project. So I'm sure Chris knows a lot about this, but they have, and there is Tomorrow BC, and so they have a system of collecting samples, phenotyping patients, and banking that data for decades. So I think that's definitely a system that we could all plug into, and it's something that we probably should be connecting with. It does include also samples collected for genetics.
And David, did you have a comment to make about this as well?
Yes, I did, because I've spoken to Elizabeth about this before, and it's a challenge for centers like that. When we set up a registry, we made it, we gave money to each individual center for each individual patient recruited. We gave money to each individual center for ethics submissions and so on and so forth. But the difficulty is the centers who have nothing to start with. A few $1,000s to recruit cardiac sarcoidosis patient isn't enough to employ a research coordinator. So I can only suggest, Elizabeth, constructive ways of trying to team up with other investigators at your center, such that you get funding from Andrew Cran's registry, you get funding from Gavin's registry, you get funding from my registry for individual patient recruitment. And, you know, if you recruit enough patients, you will more than pay your way for your research coordinator. But it's not easy when you're starting from nothing.
Okay, great discussion. We're a little bit over time. So I want to thank the speakers for both sessions this morning. I thought it was a great plenary talk. We're going to have a lunch break now and then ask people who have signed up for the afternoon subspecialty sessions to please use that link. That's a different link in your agenda to attend the afternoon sessions. And then if you're able to come back here at the end at around 4:15, we just have a couple of poll questions to ask you about feedback for how today went and planning for future years. Okay, thanks again, and we'll look forward to speaking to you all soon.